I appreciate your attention. Ultrasonic assessment of the carotid artery inner wall or Intima-Media thickness allows for precise quantification of the soft plaque burden within the carotid artery and within the circulation in general. The carotid artery Intima-Media thickness measurement correlates with the presence or absence of obstructive narrowings in the carotid artery, within the coronary artery system, or within the vasculature in general. One's carotid artery Intima-Media thickness is predictive, above and beyond that of standard risk factor assessment, of one's risk for a heart attack, stroke, or other adverse cardiovascular event. As the carotid artery Intima-Media thickness measurement is easy to obtain, non-invasive, relatively low in cost, and not associated with a risk of ionizing radiation, it lends itself well to serial follow-up. So we can track the course of your atherosclerotic disease and assess the success or failure of our anti-atherosclerotic or preventative measures. Carotid artery Intima-Media thickness assessment is clearly a new window into the arterial and cardiovascular circuits. My name is James Roberts. I'm board certified in internal medicine and cardiology. I've been practicing invasive and now integrative cardiology in Northwest Ohio over the past 22 years. I'm the medical director of comprehensive heart care, the ECP Center Northwest Ohio, and the Advanced Magnetic Research Institute of Northwest Ohio. And with my colleague, Dr. Stephen Sinatra, I'm co-author of Reverse Heart Disease Now, a patient manual of integrative cardiology. While I practice integrative cardiology today, this wasn't the fashion in which I was trained. I was trained in invasive and clinical cardiology. And as a young physician, I wouldn't see you until you presented to the hospital with the consequences of atherosclerotic plaque. You would have chest pain, or you would sustain a heart attack or a cardiac arrhythmia. We would hospitalize you in the coronary care unit, treat you with drugs, place intravascular catheters if you're hemodynamically unstable. And after you were stabilized, we would carry out a heart catheterization and then decide how we would address the consequences of advanced atherosclerosis that you had presented with, either a balloon angioplasty or a stent, a bypass, or a pacemaker. And you would get better, and we would be gratified that we pulled you out of the crisis, and you would leave the hospital feeling well, but inevitably you would return with a new problem because we were dealing with the consequences of this disease. We weren't dealing with the causes, and this was very frustrating. I was practicing revolving door medicine. So I became interested in the causes of atherosclerosis, began to put my patients on fish oils and antioxidant vitamins, and I found my patients recovered from their crises just as rapidly, if not more rapidly, but then they were less likely to return to the hospital with new disease. So my focus now is on integrative cardiology. Yes, we will manage your crises, but above all, we want to prevent another crisis or prevent the development of disease in the first place. So we look at all of your risk factors, the abnormalities in vascular biochemistry and cell biology that together conspire to cause cardiovascular disease, and this is my focus. But how do we know if we're getting the job done? Well, if you don't have another heart attack or your bypass grafts don't clog, we're getting our job done. But we would like some other measuring sticks to guide us to make sure that we are helping you adequately, that we've done enough. Well, how do we do that? For years, we would measure your risk factors on a flow sheet. We would look at your cholesterol, your lipoprotein A, your C-reactive protein, your homocysteine. And we would try to lower those numbers. But again, those are numbers. Just because I lower your cholesterol doesn't mean I'm stabilizing atherosclerotic plaque. We need more precise measurements. We don't want to measure numbers, we want to measure the disease itself. Well, how can we do that? Well, I could do a coronary angiogram on you once a year. We inject X-ray dye into the coronary arteries, create a silhouette of the flow area, and I could do an angiogram every year and see if it's changing. But the angiogram has limited precision. It can't tell the difference between a 2% or a 10% change. And that's not sensitive enough. If your arteries are changing 5% per year, that's too much. I need to know about that, and we can't rely on the coronary angiogram for that type of quantification. And it's an invasive procedure, it's expensive, there's risk. Clearly, we can't do coronary angiograms on you once a year. We were quite excited about 7 years ago when the coronary artery calcium score came out because the degree of calcification does correlate with your disease burden. But the problem with the exam is the calcification tends to progress at 40% a year for factors unrelated to atherosclerosis, and the exam is rather expensive, $500, and there's a fair amount of ionizing radiation. You wouldn't want to get a coronary artery calcium score every year. That would be too much radiation. Well, now we have the 64-slice CT and the CT angiograms, which gives us gorgeous pictures, and you can tell whether an artery is open or closed. You can tell if your bypass grafts are open or closed, and there is quantification available, but again, you can't pick up a 5% change, and that's the change that I am interested in if my job is to stabilize or even regress your plaques. In addition, these exams are expensive, $600 to $700, and again, there's ionizing radiation. The carotid IMT is a better approach. The IMT is easy to obtain with medical ultrasound, which is risk-free in the physician's office. Now, medical ultrasound will clarify differences between densities of tissues. So the ultrasound beam is directed into the carotid artery, and the blood traversing the carotid artery is not very dense, so it appears as black. The endothelial layer, or the intimal layer of the carotid artery, is dense right of the blood, so you see a white stripe. Deep to the intimal layer is the muscular layer, or the media, which is not very echodense, so you see a black stripe. We measure the Intima-Media thickness, which has been shown to correlate precisely with the Intima-Media thickness that you might record at autopsy or on a microscopic slide. Here, this is a cartoon. This is a picture in real life. We have the Intima-Media thickness of the back wall, the Intima-Media thickness of the front wall. The physics of ultrasound are such that the near wall IMT measurement is not precise. So we will focus on the far wall IMT measurement. Digital calipers are applied, and we can measure the mean or average IMT over this span, or we can measure the maximal IMT at any one point within our area of interest. And actually, we're looking at the IMT of 100 different points within the area of interest. The average is your mean IMT. The peak difference at any of these 100 points is your maximal IMT. Now, the IMT is non-invasive, it's risk-free, no ionizing radiation. It provides quantification at the sub-millimeter level. Most of you will have a mean IMT well below a millimeter, at least I hope you do. We can repeat the scan every 1 to 2 years because the IMT can change rapidly in response to medical therapy. I'm going to present you studies showing that in response to nutritional or pharmacologic interventions, your IMT may regress up to 5% within 6 to 12 months. All risk factors for cardiovascular disease will affect the IMT, and they will affect the IMT decades before they cause obstructive narrowings. I want to work with you decades before you have obstructive narrowings. The IMT value is predictive of coronary, carotid, kidney, and overall vascular status. The IMT is predictive of cardiovascular risk and event rate above and beyond any prediction you can obtain from looking at your risk factors, because the IMT integrates the plaque-producing tendency of all of your risk factors put together. Because it's not a risk factor, it's the disease itself. A change in IMT over time is highly predictive of outcome. As we will present to you, if we can regress your IMT, if we can melt it away, we can more or less guarantee you freedom from an adverse cardiovascular event. Because if your disease is getting better, you're not going to get worse. The IMT is the interface between physiology and anatomy. The IMT is the staging ground for plaque formation. If we can control the IMT, we can control plaque formation. I'd like to present the first study that came out in the cardiology literature in 1993. Dr. Jutka Salonen and his wife, Dr. Rita Salonen, presented data from the Kuopio ischemic heart disease risk factor study. Just under 1,300 men who are participating in the Kuopio study residing in eastern Finland. You're going to look at their standard risk factors, blood pressure, diabetes, smoking, cholesterol, etc. And you're going to measure the common carotid IMT. You're going to take 3 views of the far wall, the right and left carotid artery. The normal IMT is this thin stripe that you can barely see. An abnormal IMT was a stripe above 1 millimeter. Now we might call an IMT of 0.8 or 0.9 abnormal depending upon your age and gender, but for the purposes of this study, abnormal IMT was above 1. Non-stenotic plaque was a focal bulge in the IMT, a region where the IMT bulged by maybe 50%. A stenotic plaque was a bulge in the IMT occupying greater than 20% of the flow area. That's not a high-grade nilling, but it is a bulge that would be seen on an angiogram or a standard carotid ultrasound. The standard carotid ultrasound would not record the IMT or the minor plaque. Now, they did the IMT ultrasound assessment, and then they recorded cardiovascular events 1 month through 2.5 years after the ultrasound. The mean follow-up was 1 year. And they looked at heart attack, fatal and non-fatal, and cardiovascular death. And their goal was to correlate the ultrasound, the IMT findings, with the future event rate. Now, 608 of the subjects, or 47%, had normal ultrasounds. No plaque, no IMT thickening. Their cardiac event rate was 1%. 20% of the subjects had thickened IMT. They would have a normal ultrasound or an angiogram. They had thickened IMT, and their event rate was 2%. 30% had small minor plaque, which probably wouldn't be picked up on a standard ultrasound or an angiogram. Their event rate was 3%. 3% of the subjects had an obvious plaque that would be picked up by any technique, and their event rate was 5%. But half the people who had an adverse cardiovascular event would not have been picked up on an angiogram or a routine ultrasound, but they were picked up on IMT assessment, showing the advantage of the IMT assessment over standard ultrasound, standard angiography. Now, Dr. Salonen also looked at several risk factors and correlated them with the degree of thickening, and he found that smoking, a high free radical burden, deficiency of antioxidant minerals, diabetes, hypertension, high cholesterol, advancing age, and male gender were associated with an increased IMT, just as those risk factors are associated with an increased risk of cardiovascular disease in general. Now that study was published in 1993. Now in 2008, there have been 2,500 articles published on IMT, and in our 2-part presentation, I'm going to present studies associating all of these different entities with an increased IMT or increased rate of IMT progression. All of these risk factors increase IMT and increase your risk of cardiovascular disease. And then we're going to present the therapies, lifestyle, pharmacologic, and nutritional, that have been shown to stabilize or regress the IMT, which have also been shown to decrease your risk of cardiovascular disease and cardiovascular events. To summarize Dr. Salonen's study, if the ultrasound was normal, you were at low risk for an adverse event. If any abnormality at all was found on this low-cost, easy-to-obtain study, your risk is 3.3 times normal. If the IMT is thickened, which you would not see in a standard ultrasound, your risk is 2.2-fold increased. If there's a small plaque, it rises 4-fold. If there's an obvious plaque, it rises 6.7-fold. To summarize, The IMT is the staging ground for plaque formation. It is the interface between abnormal physiology and abnormal anatomy, the high-grade plaques that cause your chest pain and cause your heart attack and stroke. All risk factors for cardiovascular disease affect the IMT. The IMT, above and beyond standard risk factor assessment, predicts your current cardiovascular status and risk, and of more importance, your risk 6 to 10 years into the future. All therapies shown to be beneficial in the prevention and treatment of cardiovascular disease have been shown to be beneficial in stabilizing or regressing the IMT finding. That concludes the introduction of our presentation. We'll now move on to the section that covers the normal or population expected values of the IMT. What are the normal or population expected values of the IMT? Before we discuss abnormal values, we must define what is normal or expected. Let's start with 453 Londoners, asymptomatic individuals, men and women aged 35 to 75. We're going to designate 137 of these 453 Londoners as ultra healthy, people who life insurance salesmen would love to sell a policy to. They had a normal blood sugar, their cholesterol's low, their blood pressure's normal, they're not overweight, their body mass index is normal, and there was no obvious plaque on their carotid ultrasound. The remaining 316 had one or more of the standard risk factors, and in this group, you're going to calculate their predicted 10-year coronary event rate based upon the Framingham data. The Framingham study was a large epidemiologic study carried out in residents of Framingham, Massachusetts. They looked at standard risk factors, blood pressure, cholesterol, smoking, and correlated that with their event rate over 20 years. And in the Framingham protocol, points are assigned for smoking, blood pressure, cholesterol, etc. And you can, from these standard lifestyle and risk factor markers, you can predict one's 10 or 20-year risk. And that was done for the Londoners that did have risk factors. Then they carried out carotid artery intermediate thickness, the far wall, the left and the right carotid arteries, they obtained the mean IMT of the common carotid artery, the mean IMT of the bifurcation, which I'll discuss in a minute. And the question is, how well does the IMT correlate with standard risk factor assessment, and what is the effect of age on the IMT parameters? Here, we're going to look at the mean and 98th percentile values for the common carotid artery mean IMT as a function of age. You can see that the mean values rise slowly with age. The 98th percentile values, the 98th percentile is 2 standard deviations above the mean, which is the statistical limit of normal. And they were looking at the IMT and the common carotid artery, and the message is, in the ultra healthy normal people, the IMT progresses slowly over time. If we look at the IMT, the mean and the 98th percentile at the carotid bifurcation, we see the same pattern. The values rise slowly and inexorably with age. Now, of interest, you can see that the IMT in the bifurcation is somewhat greater than the IMT in the common carotid artery. Plaque forms in areas of turbulent flow where there are eddy currents at branching points. So we typically see a greater IMT and a greater frequency of early plaque formation when the common carotid artery bifurcates into its internal carotid artery and external carotid artery limbs. The internal carotid artery serves the brain, and this blockage in the internal carotid artery is what would cause a stroke. So we can see that the IMT value in normal, ultra healthy people will progress very, very slowly with age. Looking at the data from another angle, here's the IMT in the common carotid, IMT in the bifurcation as a function of increasing age, slow and steady increase. It's always a little bit greater at the bifurcation than in the common carotid artery. Now we're going to look at the IMT in the common carotid artery and in the bifurcation amongst these asymptomatic individuals that had risk factors. Those who were felt to be at higher risk for an adverse event based upon their constellation of risk factors such as diabetes, smoking, high blood pressure, etc., you can see that their IMTs were greater than individuals who were ultra healthy or had a lower risk factor burden. So the standard risk factor assessment does correlate with the IMT. Because the risk factors that one bears causes abnormal physiology, which leads to an increased IMT, which is the staging ground for obstructive plaque. So it makes sense that your risk factor burden correlates with an increased IMT. The IMT is measuring the net effect of all of your risk factors. So IMT in normal healthy people will rise slowly with age. The IMT will be greater in individuals as a function of increasing risk factor burden. Let's move on to the ARIC study, Atherosclerosis Risk and Community Study. This was a large study done in the United States, just under 13,000 middle-aged Americans aged 45 to 60, none with known cardiovascular disease. Now, some had cardiovascular disease they didn't know about, but none had known cardiovascular disease. These individuals lived in 4 communities scattered throughout the United States. You're going to measure the mean IMT of the common carotid artery and determine what we might call normal or no known cardiovascular disease population values, stratified by age, race, and gender. And the ARIC study gave us information that has been corroborated by many other studies throughout the world that in healthy individuals without known cardiovascular disease, the IMT progresses by 0.010 millimeters per year. Another way of stating that is 10 micrometers per year. To make it easier on me, instead of saying 10 micrometers per year, I'm going to say 10 points a year. If you work diligently on your risk factors or begin some of the therapies that we'll talk about in the second DVD, we may slow down the rate at which your IMT progresses. You may fall from 10 to 5 micrometers per year. I'm going to say that would be 5 points. On the other hand, if you have multiple risk factors that you're not addressing, your IMT may be progressing more rapidly than that of the average American, which is a bad sign. You might be progressing at 20 micrometers per year or 0.020 millimeters per year. I'm going to call that 20 points. So to make it easier for me, 10 points is 10 micrometers per year. Now, here we have the common carotid artery mean IMT by age bracket. Here we have white men on the top, white women below. Age 40 to 50, age 50 to 60, age 61 to 70. You can see the mean values are rising slowly with age. We have the mean values and the 5th percentile, the 95th percentile. You can take your own number and plug it into your age group and see how you stand related to your peers of otherwise healthy Americans. For example, if your IMT is 0.77 and you're 65 years old, you're smack dab in the middle of average. However, if you're 45 years old and your IMT is 0.77, you're going to be in the top 25%. So we attribute risk to IMT in relation to your age. Women, their average IMT values are slightly below those of men, which makes sense because women have less cardiovascular disease than men, at least at young age. But women, just like men, the IMT values will progress over time. Here we have the mean common carotid IMT in a 45-year-old and in a 65-year-old. Here we have the 50th percentiles, and we can stratify from the 5th to the 95th. And you can plug yourself into these charts and see how you stand. Women, your IMT will be a little less than that of men, but it progresses slowly over time with aging. Black men and black women have slightly greater IMT values than white men and women. We don't know if this is because blacks have more atherosclerosis than whites, or maybe it is a normal variant racial difference such as bone density. The difference is very minimal, so in the vast majority of the studies, no distinction is made between race. A distinction is often made between gender because male values are typically greater than female values. The ARIC study looked at middle-aged Americans, age 45 through 65. We would like to begin our preventative work before middle age. The Bogalusa Heart study looked at intermediate thickness IMT in younger Americans. 519 healthy 20 to 38-year-old men and women who lived in Bogalusa, Louisiana. You're going to measure the common carotid IMT, again the far wall, and stratify by age, race, and gender. The IMT in white men was 0.668 millimeters and in white women 0.644. Values in black men and black women were slightly greater. As in the ARIC study that focused on middle-aged Americans, within the Bogalusa study, you can see that the IMT rises slowly with age, here in men, here in women. Now here we have the increasing age brackets in the Bogalusa study. On the right, we have increasing age brackets in the ARIC study. And in the Bogalusa study, at age 25, it's 0.615. At age 30, it's 0.646. At age 40, it's 0.708. Slow progression. In the ARIC study, at age 45, you're 0.6, slow progression. But you see a discrepancy here because the average value in the 40-year-old men in the Bogalusa study is 0.708, and in the 45-year-old men in the ARIC study, it's even lower at 0.6. That doesn't make any sense. Well, perhaps the individuals who live in Bogalusa are a sicker group of people with greater IMTs, but that's not really the explanation. I'm tricking you here a little bit to make a point. In that, in the ARIC study, they utilized mean IMT values. In the Bogalusa study, they utilized maximal values. In the typical report that we have right here, you can see in this individual, the mean value was 0.77 and the maximal value was 0.860. Again, we're looking at 100 little differences here to get the mean or the average value. If there are tiny little blips or bumps in the IMT, that would be the maximal value. So it's not appropriate to compare the maximal values in Bogalusa with the mean values in ARIC. And the reason I presented it this way is to make a point. If you are looking at your report, which gives you mean and maximal, you want to plug yourself into the studies. You want to pay attention to, were they looking at mean or maximal? Otherwise, there'll be a great deal of confusion. Now, again, even if you look at the maximal value in Bogalusa or the mean value as in the ARIC study, there's a slow progression every year. In the ARIC study, the men and women progressed at 10 points per year. In the Bogalusa study, white men progressed at 9 points per year, white women at 5.5 points, black women at 6.2 points. There weren't enough data points to allow yearly progression in black men. As a general rule, younger people, as in Bogalusa, progress a little more slowly than do middle-aged and older adults who progress at about 10 points per year. And again, 10 points per year is the standard. If you're progressing faster than 10 points a year, that's bad. If you're progressing below 10 points per year in general, that's a favorable finding. Now, IMT in seniors. These are studies that I'll present later on. In the coronary heart study, we're going to look at maximal, or we call mean maximal. It's the average of all the maximal readings of the common carotid in seniors. Individuals enrolled in Medicare, the first quintile is below 0.87. The fifth quintile is above 1.18. A study done of residents of Rotterdam in the Netherlands, you look at common carotid artery in individuals at least 55 years of age or older. You can divide it by, the mean is 0.8. The first tertile is below 0.72. It increases in the second and third. A study of just over 5,000 Germans enrolled in a primary care network. The mean common carotid is 0.725. Individuals below 50 the average is 0.65. Above 50, the average is 0.8. Again, across the world, the IMT is rising slowly with age, and you can take your own numbers and plug yourself into the studies where they were sampling IMT in individuals who are like you as a function of age, gender, and health status. Another study of IMT in younger individuals, the Muscatine study, 346 men and women aged 33 to 42 who lived in Muscatine, Iowa. Now, in this study, we're going to begin to discuss the effect of risk factors at various points of life on your adult IMT. They looked at standard risk factors during childhood, ages 8 to 18, during young adulthood, ages 20 to 23, and during adulthood, ages 29 to 37. And at around age 40, they measured the IMT, and they found a value of 0.72 in men and 0.79 in women, and this is the mean maximal, the same measurement that was used in the Bogalusa study. And they looked at your risk factor burden during childhood, as a young adult, as a relatively mature adult, if a 40-year-old's a mature adult, and I think they are, and the overall risk factor burden in men and women. And they found that in childhood, in women, body mass index, which is weight, overweight, cholesterol, systolic and diastolic blood pressure, and triglycerides were predictive of an increased IMT at age 40. And in men, it was the cholesterol. The overall load, childhood, teenage, young adult, for women, it was the LDL cholesterol, weight, and triglycerides. In men, it was the LDL cholesterol, HDL, and diastolic blood pressure. Here we have increasing levels of cholesterol in terciles in men and in women, and the greater your cholesterol as a child, the greater was your IMT at age 40. The message here being we need to work with risk factor reduction in our kids. We used to feel that when you were young and healthy, it didn't really matter what you do. You clean up your biology later on, you will not get adult disease. That's not the case. Bad habits, bad dietary habits, lack of exercise, overweight as a kid increases your risk of having cardiovascular disease as an adult, as evidenced by an increased IMT. The ARIA study was a similar evaluation of 750 young men and women aged 27 through 30 who resided in the Netherlands. You're going to measure their mean common carotid IMT, and it was 0.49 in men, 0.48 in women, and you're going to look at all the standard risk factors and correlate that with their IMT. And the most important predictors were age. As we age, our IMT increases. Overweight, pulse pressure, that's a high systolic and a low diastolic that slaps at the artery, male gender, and LDL cholesterol. They also looked at smoking, and if we look at increasing pack years in men and in women, that is associated with a significantly increased IMT. So young people who think they can smoke and then quit later on and that it's not going to cause any damage, that is not correct. The more you smoke as a young adult, the greater will your IMT be, the greater will be your risk of future cardiovascular disease. The researchers looked at the number of risk factors, overweight, blood pressure, triglycerides, LDL, versus IMT. Here we have women, here we have men. Increasing risk factor burden was associated with an increasing IMT. Then they divided the subjects into quartiles, 25% brackets of IMT, the first through the fourth, and they looked at their risk factors and plugged them into the Framingham data, and they found that individuals who were in the top 25%, the upper quartile for IMT, if you looked at their Framingham parameters, their 20-year risk of having a cardiovascular event was 28%. Now, when I'm 30 or 40 years old, I would not want a constellation of risk factors and an increased IMT giving me a 28% 20-year risk. This just shows that we need to be vigilant when early in life, well before we get sick. We don't want risk factors. We don't want a high IMT at any point in life, because a high IMT at any point in life is associated with a greatly increased risk of cardiovascular disease. So to summarize the normal or population expected values, The IMT typically rises with age, typically 10 points or 0.01 millimeters or 10 micrometers in adults. The IMT will progress in kids and young adults, but a little bit less rapidly. There are gender and racial differences. Men have greater IMTs than do women. Blacks have slightly greater IMTs than do whites. Your IMT rises with increasing risk factor burden in all age range groups. We emphasize that in kids. Smoking, overweight, high sugar, cholesterol in childhood is associated with an increased IMT as a young or mature adult. So you have your report in front of you. You have your mean and your maximal values. You can plug yourself into the charts, but pay attention to the appropriate age range, mean versus maximal IMT values, and appropriate clinical status. Some of the studies that we're going to present were of healthy people without known cardiovascular disease. Others focused on individuals with known cardiovascular disease who are going to have greater IMT values. So you want to plug yourself in to the study that corresponds to your age, gender, race, and clinical status. Now we're going to move on to using the IMT to predict the presence of obstructive arterial disease. In this section, we're going to discuss the use of the IMT in predicting the presence, absence, or extent of obstructive arterial disease. Can we use the IMT to predict who's going to have a high-grade narrowing and who will not? Can differences in the IMT value be utilized to differentiate single vessel from multi-vessel coronary disease? Now, can we use the IMT to predict one's calcium score? Because coronary calcification, biochemical scarring, is predictive of disease burden and future event risk. When I was trained, we made all of our decisions based on the coronary angiogram. We felt that these narrowings were concretions, fixed blockages, that were not responsive to physiologic phenomenon, and that the patient's symptoms were due to a supply-demand imbalance. The supply of oxygenated blood was not sufficient to meet the needs, the demands of the patient's heart muscle. So cardiology was all about fixing blockages, supply and demand. We made all of our decisions based upon the coronary angiogram, which was the gold standard. But over the years, we learned that the coronary angiogram is not really a gold standard, or at least it's a little bit tarnished. We would use the coronary angiogram to make decisions. Should a patient undergo an angioplasty, a bypass, or a stent, or be treated with drug therapy? We felt that the arteries would narrow with plaque in a smooth, concentric fashion. And when we inject dye into the coronary arteries to obtain a silhouette, we can accurately predict or measure from the angiogram the amount of plaque in the arteries because it's smooth and concentric. But this is not the case. We can now do intravascular ultrasound, or IVUS. We have a catheter with an ultrasound crystal at the tip. We can actually measure the thickness of the Intima-Media of the coronary artery. This is the exact same measure we are looking at with the carotid artery IMT. And what we're finding with the intravascular ultrasound is that the plaques are not smooth and concentric, they may be eccentric. And what appears on an angiogram to be a mild to moderate narrowing is actually a huge plaque full of freshly oxidized inflamed cholesterol. The plaque may be eccentric and it may be vulnerable. Here's an individual whose angiogram shows a moderate narrowing. You would call that a 50% obstruction. No big deal, but the IVUS shows that that 50% obstruction is actually a large, eccentric, vulnerable plaque. So the angiogram does not tell the whole story because it's not measuring IMT intermediate thickness or soft plaque deposition in the carotid artery. It's simply a silhouette. We've talked about vulnerable plaque. You've heard stories of individuals who saw their doctor because they weren't feeling well. They had a stress test. It was normal. They went home. 2 weeks later, they had a heart attack and died. How can that be? Our stress tests pick up only high-grade or flow-limiting narrowings. For your stress test to light up, you need a 50 to 70 to 80% narrowing. There are many individuals who have moderate narrowings, 40, 50, 60, but who have vulnerable plaque. Vulnerability in plaque has nothing to do with the percent narrowing. It has very little to do with the amount of cholesterol in the artery. What it has to do with is the physiology of the endothelial cells. This is a single layer of thin cells that govern the biochemistry of arterial health. The endothelial cells, when healthy, make nitric oxide and other vasoprotective chemicals that provide the Teflon coating to the artery, causing it to resist spasm or platelet clotting or cracking. I would prefer to have an 80% narrowing with a healthy endothelium as opposed to a 40% narrowing with a sick endothelium. The individuals with normal stress tests who died 2 weeks later, they had a 40 to 50% narrowing, but the endothelium was dysfunctional. They couldn't make nitric oxide. These individuals will rupture or crack or fissure their plaque or have a platelet clot, and they will die suddenly of a large heart attack. There are many individuals with vasospastic angina. Their angiograms are normal. There's no plaque or very little within the artery, yet they will have symptoms. They will have chest pain. Blood flow can be impaired because their endothelial function is poor. They cannot make nitric oxide. So the angiogram does not tell the whole story. It does not really tell us the degree of plaque buildup. It doesn't tell us the intermediate thickness of the coronary artery. And above all, it doesn't tell us about vulnerability. Vulnerability is an abnormality in physiology. And as you are going to learn, abnormal physiology, endothelial dysfunction, vulnerability leads to an increased IMT, which leads to obstruction and abnormal angiogram and an increased event rate. How can we measure endothelial function? We can do it invasively. Here's an individual who has a coronary angiogram with a very modest narrowing. And in the cath lab, you inject acetylcholine into the coronary artery. Acetylcholine is an endothelium-dependent vasodilator. If the endothelium is healthy, the cells make nitric oxide and the blood vessel will dilate. Conversely, acetylcholine is an endothelium-independent vasoconstrictor. If the endothelium is not healthy, the smooth muscle in the artery will constrict. This individual had poor endothelial function in response to acetylcholine, didn't make nitric oxide, had a tight vasospasm. That person would be experiencing chest pain. You would treat them with intracoronary nitroglycerin. Nitroglycerin gives you nitric oxide as a drug effect. The vascular smooth muscle will relax and the blood vessel will open up. So these are not concretions. They are dynamic narrowings response to physiologic stimuli. So this man had a modest narrowing and endothelial dysfunction. They brought him back about 4 years later and did a coronary angiogram. They didn't inject nitroglycerin or acetylcholine, but you can see he has a high-grade narrowing. Just 4 years later, he went from a 20% narrowing to a 90% narrowing in 4 years. You can also see that the presence of endothelial dysfunction predicted that this man would worsen anatomically, and it predicted the point of worsening, because physiologic abnormalities precede and lead to and cause anatomic abnormalities. We prefer to measure endothelial function as an outpatient in the office. How we do it, we will measure the diameter of the brachial artery at your elbow here. We will pump up a blood pressure cuff to 50 points above systolic. So we're going to be decreasing arterial blood flow to your arm for 5 minutes. You'll be a little bit comfortable. That will not harm you. Then we release the cuff. Arterial blood will gush into the arteries of the upper extremity. As blood flow increases, as it soars through the arteries of the upper extremity, the blood flow will exert a gentle radial shearing stress against the endothelial cells that line the artery. If the endothelial cells are healthy, they will respond by making nitric oxide, and the blood vessel will dilate about 10%. If the blood vessel does not dilate, that is a sign of endothelial dysfunction. Hundreds of studies have shown that endothelial function measured in the arm correlates with endothelial function measured invasively in the coronary artery. They're all one and the same because it's your vasculature, it's your physiology that we're measuring. Now, it doesn't matter how you measure endothelial function in the cath lab or in the arm. Individuals with intact endothelial function are blessed. They do not have events. Even if you have significant coronary disease, if we can rescue your endothelium, we can dramatically decrease your event rate. Conversely, the worse your endothelial function at any stage of obstructive coronary disease, the worse is your outcome. If your endothelium is shot, your physiology is shot, and you're doomed. Your disease is going to progress, and you're at great risk for an adverse event. Consider external counterpulsation, my procedure that we use on individuals who are inoperable. Their arteries are totally blocked, yet we can improve them not because we're changing their anatomy, but because we're changing their physiology, their endothelial function. In this procedure, we apply pneumatic cuffs to the patient's lower extremity and generate a retrograde pressure wave. We're going to propel oxygenated blood into the arteries and bypass grafts serving the heart in between heartbeats when the heart is ready to receive this blood, and we can generate natural bypasses. It is not uncommon to find patients who have a totally blocked artery. They did not have a heart attack. They don't have much in the way of symptoms because at the time that this artery was closing, their physiology was fairly well preserved and they made natural bypasses. So just because we see a high-grade narrowing, that doesn't mean that you're going to have a heart attack. Actually, most individuals who have heart attacks, this occurs when a moderate narrowing closes suddenly. When a high-grade narrowing closes, you will have had time to form natural bypasses. You tend to have a smaller heart attack or not at all. The point of all this is that physiology, as measured by endothelial function, and IMT is perhaps more important in predicting outcome than is your anatomy. With external counterpulsation, we don't change your anatomy, we change your biochemistry. We generate angiogenic growth factors. We double nitric oxide production. Antioxidants levels increase, oxidants fall. Flow-mediated vasodilatation, a marker of endothelial function, triples. And what happens is, while we haven't changed your anatomy, we've changed your physiology. You can walk much farther on the treadmill, and blood flow, as determined by a nuclear stress test, will improve. Physiology is more important than anatomy. We're concerned about your anatomy, but I really want to work at the level of the physiology because the physiology governs the anatomy. The importance of the IMT. It is the interface between physiology, the all-important endothelial function, and anatomy, plaque. Abnormalities in your risk factors compromise your physiology, which leads to an increased IMT, the staging ground for obstructive plaque. By measuring the IMT, we can look at this interface between physiology and anatomy. The risk factors for IMT are shared with those of endothelial dysfunction and plaque formation. It's all the same process being measured at different levels and via different means. The Intima-Media is the staging ground for new plaque formation. If we can control the IMT, we can control new plaque formation. The IMT is a powerful predictor of your current cardiovascular status and your future outcome. Short-term changes in your physiology in endothelial function are reflected in the IMT measurement. It can change significantly in 6 to 12 months. The obstructions in your arteries will not change significantly in 6 to 12 months, but we're not that concerned because it's your physiology that we must gain control of. A small change in the IMT leads to a powerful effect on future risk and outcome. Now, having stated that there are some limits to the angiogram, we still are interested in the status of your coronary arteries. Can we use the IMT to predict who will and who will not have obstructive arterial disease? We'll describe the obstructive arterial disease on the angiogram as percent stenosis, the percentage of the tube, the percentage of the flow area that is narrow. Here we're going to look at 390 consecutive subjects undergoing elective coronary angiography. None had known coronary disease, none had unstable symptoms, mean age 60. You're going to measure their IMT, the mean IMT of the common carotid artery and the internal carotid artery. You're going to do the coronary angiogram. 340 of the men had a significant narrowing. 50 did not have a 50% narrowing. They were the control group. We're going to correlate the carotid IMT with the angiographic findings. And what you find, the individuals that did not have 50% narrowings, their mean IMT was 0.68. Those with coronary disease was 0.78. This is in the common carotid. If you looked at the internal carotid, similar relationship. 0.66 in those that did not have obstructive coronary disease, 0.85 in those who did. This makes sense. If you do not have a lot of risk factors, your endothelium is preserved, you will not have a high IMT, you are less likely to have obstructive disease. If we look at the internal carotid mean IMT, in those that did not have obstructive disease, it's 0.66. Those with one vessel disease, it's 0.83. Two vessel disease, it's 0.86. Three vessel disease, it's 0.87. So the greater your IMT, the greater is the likelihood that you have obstructive coronary disease. The greater the IMT, the greater is your extent of coronary disease, the more vessels involved. In all subjects, if they just used the common carotid mean of above 0.8 or the internal carotid mean above 0.85, those parameters had a 70% sensitivity and specificity in predicting obstructive coronary disease. So if you're my patient and we're thinking about a heart cath and I say, well, instead of the heart cath, let's just do the carotid IMT. And if I use these cutoffs, I would be correct in labeling you disease, yes or no, 70% of the time. In subjects below the age of 60, all the disease-free controls, all those who did not have an obstructive lesion, had a common carotid and an internal carotid mean value below 0.8. All the patients with disease had a level above 0.8. So in subjects below 60 years of age, in theory, you wouldn't do the heart cath at all, you would do the IMT, because if you were below 0.8, you didn't have an obstruction. If you were above 0.8, you did. Now, in the real world, we're not going to make decisions based on a single measurement, but it just shows the predictive power of the IMT. The greater the IMT, the greater is your risk of obstructive disease. Another study, 170 consecutive men and women presenting for coronary angiography. This was a sicker group of people. They were acutely ill. They had chest pain, heart attack, valvular disease, cardiomyopathy, but none had had a prior intervention or revascularization, mean age 58. You're going to do the ultrasound and look at the mean maximal IMT of the common carotid artery, and you're going to look for the presence of plaque, which in this study was a focal bulge in IMT of 50%. So if the average IMT was 1 and there was an area of 1.5, that would be called plaque. And plaque was found in 58% of these individuals. You do the coronary angiogram, 81% had a significant narrowing, the rest did not have significant disease. You're going to look at their standard risk factors, you're going to correlate the IMT with the angiographic findings and their risk factors. And what you'll find that 30% did not have carotid plaque. Those with single vessel coronary disease, 45% had carotid plaque. Two vessel coronary disease, 65% had carotid plaque, and so on. So the more obvious plaque in your carotid artery, the greater is your risk of obstructive plaque in the coronary arteries. That makes sense. If you look at the mean maximal IMT of the common carotid artery. Those without obstructive disease, it's 0.65. Those with single vessel disease, it's 0.78. Two vessel disease, 0.88, and so on. Again, the greater your IMT, the greater is your risk of obstructive coronary disease. The greater is your IMT, the more extensive we would predict your coronary disease to be. They're looking at the predictors of obstructive disease. Of all the risk factors and the IMT parameters used, the most significant predictors were the IMT, the age, and the HDL cholesterol. The presence of carotid plaque was not predictive. Plaque in the carotids and in the coronaries is the product of IMT. IMT is the staging ground. So if your IMT is high, it predicts the development of plaque. So the IMT is a better predictor than is the presence or absence of plaque, because plaque is the product of IMT. In this study, if the IMT was 0.75 or above, there was a 78% sensitivity and specificity for predicting that 50% narrowing. So if we didn't do the heart cath and just looked at your IMT and used 0.75 as a cutoff, we would be correct in classification 80% of the time. In a study of hypertensives undergoing urgent angiography, a sicker group of people, the same relationship. The greater the IMT, the more extensive will be your coronary disease. So in all populations, relatively healthy people, relatively sick people, the greater the IMT, the greater is your risk for obstructive coronary disease, and the greater is your risk for extensive coronary disease. I've made this statement that the IMT is the staging ground for plaque. In this study, we're going to see how well IMT predicts future plaque formation. We're going to look at just over 1,000 registered voters in Nantes, France, aged 59 to 71, none with known cardiovascular disease. At baseline, at 2 and at 4 years, you're going to carry out an ultrasound and measure the mean common carotid IMT. And this is not within an area of plaque. We typically measure IMT away from an area of plaque because we're interested in IMT, not plaque. And the men and women were divided into quartiles, first, second, and third, and fourth, and you can see the IMT values are rising as you'd expect. Then you're going to look at the presence of plaque, which in this study was defined as IMT above 1 millimeter. On the first study, in any of the vascular regions, the common carotid, the bifurcation, or the internal carotid. And when we are doing the IMT assessment, we're not only measuring the IMT, but we can look for plaque. Here's somebody with a 20% soft plaque. This individual has a 20% hard plaque. You can see it's calcified. This individual has a high-grade obstructive narrowing in the internal carotid artery just beyond the bifurcation. So while the IMT was being done as a part of a risk factor reduction protocol, we stumbled across a high-grade narrowing in a patient that might require surgery or at least aggressive therapy. So while we're looking at the IMT, or measuring the IMT, we're looking at the entire artery, and we can find plaque in our patients. They looked at the IMT, and they correlated that with the development of new plaque. They looked for the degree of plaque at baseline, and then new or additional plaque on the 2 and 4 year studies. And the question is, could the baseline IMT predict future plaque formation? Now, at baseline, individuals who had plaque at baseline, 18%. New plaque above and beyond baseline occurred in 19%. New plaque development occurred in 33% of those who had plaque at baseline. If you have plaque at baseline, you're more likely to have new plaque. It occurred in 15% of those who did not have plaque at baseline. Now, let's look at the relative risk for new plaque formation over 2 and 4 years as a function of your baseline IMT. Those in the first quartile, the lower 25% bracket for IMT, were at low risk for new plaque formation. As your baseline IMT increases, your risk for new plaque formation increases. Those in the fourth quartile were 3.6 times as likely, as those in the first quartile to develop new plaque over 2 to 4 years. Relative risk for new plaque in men and in women rises with baseline IMT. Again, the IMT is the staging ground for new plaque formation. IMT and kidney disease. We've been talking about the link between IMT and coronary disease. Later we'll talk about the link between IMT and carotid disease. Here we're going to look at the link, if there is one, between IMT and the kidney. And when you think about it, the kidney is really a vascular organ. It's a sieve that filters the blood, and it filters the blood through capillaries. So any disease state that is damaging or deleterious to our arterial circuit, we would expect could be damaging to the kidney, and indeed that is the case. This is data from the INVADE study, the Intervention Project of Cerebrovascular Diseases and Dementia. 3,364 subjects residing in Ebersberg, Germany, and they were all covered by the same health insurer, Allgemeine Osteoarzt, otherwise known as AOK. So if you go to your doctor and you're calling for an appointment and they ask you, do you have insurance, say AOK. Well, you're AOK, you can come see us. So all these people had AOK insurance, and they're all 55 years of age or older. At study entry, you look at the mean common carotid IMT, risk factors for cardiovascular disease and kidney disease, which are actually one and the same, and a measure of kidney function called the GFR, or glomerular filtration rate. And 100 is perfect. 60 is defined as kidney disease. So you're going to exclude from analysis 18% that had pre-existing kidney disease, GFR below 60. You're going to exclude from analysis a few people that had supernormal kidney function. So you're going to be left with 2,751 subjects with basically normal kidney function. 2 years later, you're going to repeat the GFR, the assessment of kidney function, in these subjects, and you're going to correlate baseline IMT with future change, positive or negative, in kidney function. Now, over 2 years, the glomerular filtration rate stayed normal. It stayed above 60 and 79%. But in 16%, it decreased moderately. In 4%, it decreased significantly, severely, and 1% they went on to have dialysis. Now, here we can look at risk markers in those who maintained intact kidney function and those whose kidney function decreased. And factors such as age, diabetes, blood pressure did play a role, but the most important predictors were female gender. Most of the time, men do worse with cardiovascular disease than women, but in this study, women were more likely to experience a deterioration in kidney function. Diabetes, for every 1% elevation of the hemoglobin A1C, reflecting poor sugar control, the risk increased by 29%, but for every 100-point increase versus their peers in the mean common carotid IMT, the risk increased. Systolic blood pressure, the only thing that was protective was the use of angiotensin converting enzyme inhibitors, which incidentally have a favorable effect on IMT. The point of all this is that as your IMT increases, that's not only predicting deterioration in cardiovascular health, it's predicting a deterioration in kidney health. If we divide the subjects into quartiles of IMT, the first quartile is below 0.66, the fourth quartile is above 0.88. If we look at the 2-year decline in GFR, normally it should not decline more than 1 to 2 points per, about more than 3 points per year. Those who were in the fourth quartile declined 15 points per year. Those in the first quartile declined a more physiologic 8 points per year. A 10-point increase in IMT over your colleagues increases your 2-year risk for kidney decline by 17%. This is similar to the studies looking at your relative risk for stroke and heart attack as a function of IMT. A 10-point change will increase your stroke risk by 15%, your heart attack risk by 18%. The point here is that IMT is increasing your risk of all cardiovascular phenomenon: stroke, heart attack, renal decline. Can the IMT predict, does it correlate with cardiovascular calcification? Cardiovascular calcification represents biochemical scarring, a passive response to cell death within the vascular wall. Now, it is stated that coronary calcification can only progress, and on average it progresses at 40% per year. In studies that have been published in the cardiology journals, statin therapy and antioxidant therapy can slow down the rate of progression of calcification, but no one feels that it is possible to arrest or reverse calcification, and of course this is not true. If we work hard enough, we can stabilize and reverse coronary calcification. This gentleman, we dropped his score from 8,500 to 6,600. These are huge scores. 400 is considered markedly abnormal, and this man dropped 2,000 points. And if we work hard enough, we can do this, and there's a number of individuals who I worked with who did lower their calcium score, although this is a great deal of work. Can we use the IMT to predict the calcium score? What is the correlation? Here we're going to look at 278 senior Americans who participated in an epidemiologic study done in Northern California called Rancho Bernardo. Their mean age was 68 with a range of 55 to 99. So these are senior Americans. At baseline, you're going to look at their standard risk factors. You're going to do the carotid ultrasound and look at the mean maximal of the common carotid and the internal carotid. They consider the 80th percentile, the upper quintile, as abnormal, with a common carotid above 1.04 or an internal carotid above 1.9. So you do the IMT, stratify them, and then 3 years later, you do the coronary calcium score. And they felt in their scheme, 0 to 10 was normal or minimal, 11 to 99 is mild disease, 100 to 399 is moderate disease, above 400 is severe. Can the IMT predict your calcium score 3 years in the future? Well, if it predicts, if it's the staging ground for plaque, and the calcium score reflects plaque, we would predict a correlation between IMT and future calcium score. Here, let's look at the mean maximal IMT of the common carotid in red or the internal carotid in blue versus increasing calcium score. You can see that the IMT is greater in individuals with greater calcium scores. So there's a correlation between IMT and coronary calcification. Here, I present the data a little bit differently. On the left is common carotid, on the right is internal carotid. With increasing degrees of calcification, you can see increasing Intima-Media thickness values. Now, let's say your goal was to predict the calcium score, and they did that for research purposes. If you wanted to predict a calcium score above 400, if you're and used as a cutoff the 80th percentile for common carotid IMT, which is above 1.04, you would pick up a third of the individuals, so it's not that sensitive, but it's highly specific with 85%. If you used that 1.04 to predict a coronary calcium score of 800, you would have a high specificity and a reasonable sensitivity. You could do the same exercise with the internal carotid. And what this means is it's unlikely to have a really high coronary calcium score without a thickened IMT. Now, the goal of doing the IMT is not to predict the calcium score. I presented that study to establish the correlation, which is logical, it makes sense. Here, we're going to look at predicting risk in seniors using the IMT and or the calcium score, which is best. If you had to pick one over the other, which would you choose? The calcium score costs 2.5 times what the carotid IMT does, and it exposes you to radiation. So you wouldn't want to do that every year, but still, if the calcium score provides much better data, you would favor it. Let's compare them in an apples to apples fashion. We're going to look at 559 men and women above 70 years of age. The mean age is 80, so they're senior Americans. You're going to look at the prevalence of pre-existing cardiovascular disease, their standard risk factors. You're going to do the coronary calcium score to look at their calcification burden, and you're going to do the carotid IMT. You're going to look at the maximal or the mean maximal, the common carotid and the internal carotid. And you're going to follow them over the next 5 years looking for event rate. 23% had a significant cardiovascular event, 9% a heart attack, 5% a fatal or non-fatal stroke. Which non-invasive measure, IMT or the calcium score, was the best predictor of outcome? Here we have the coronary calcium scores arranged in increasing quartiles. Here we have the common carotid and the internal carotid mean maximal IMT values arranged in quartiles. Here we have the calcium score arranged in quartiles in a graphic fashion. Here we have the common carotid in blue and the internal carotid in red, quartiles arranged in the first through fourth quartile in increasing fashion. Now, let's look at event prevalence of disease states versus increasing coronary artery calcification scores. Now, prevalence is pre-existent disease and events that occurred within the 5-year period. You can see that as the degree of coronary calcification increases from relatively low, the first, to the fourth quartile, the event rate increases. Similar relationship for heart attack or cardiovascular death, not as strong a predictive relationship for stroke. Now, if we look at event prevalence versus the common carotid mean IMT, a similar relationship. The greater your IMT, the greater is your risk for an adverse event. If you were in the fourth quartile for IMT, your risk for a heart attack and death or stroke was particularly high versus those with lower IMTs. So in this analysis, the carotid IMT had greater discriminating or predictive value in predicting event prevalence. We're not really interested in event prevalence as much as event incidence, which is new disease in people that did not have the pre-existing disease. We want to look into the future. And here we have the data for the coronary calcium score, slow progression, increasing risk for cardiovascular event, heart attack and stroke, and a better discrimination between the fourth quartiles and the lower quartiles for cardiovascular event, heart attack, or stroke. So in this comparison, apples to apples comparison, the carotid IMT was a better discriminator or predictor of who was going to get into trouble. Individuals in the fourth quartile with high values of IMT were at dramatically increased risk for an adverse event. So if you're coming to me as a patient and we're trying to decide how aggressively we should treat you, how hard we should work on your risk factors, and I do an IMT and you're in the upper quartile, I know that your risk is far greater than that of the next patient whose IMT is lower, so I'm going to really focus hard on controlling all of your risk factors. You have much more to gain. If we looked at relative risk of a new event versus the first quartile for IMT, here we have in blue the second, in red the third, and in yellow the fourth quartiles. You can see that in the fourth quartile, the risk increases dramatically with IMT. The discriminatory power is not as great with the coronary calcium score. Now, we've been talking about studies comparing the carotid IMT, which actually measures plaque, with the coronary angiogram, which is a silhouette. In this study, we're going to look at carotid IMT, coronary artery percent stenosis as assessed by angiography, and coronary artery IMT is assessed by IVUS. They took 48 consecutive patients requiring intravascular ultrasound. Now, we don't do intravascular ultrasound on all patients. We do it when we can't make up our mind what to do based upon the angiogram. The IVUS catheter is relatively large and bulky, so there's some risk associated with doing the IVUS, so we don't do it routinely. We do it when we have a question that needs to be answered. Consider this patient. They have a non-obstructive narrowing in the left main coronary artery, and they've got a borderline narrowing in the left antrum descending. Now, if that's a 50% narrowing and it's jeopardizing the whole front wall of the heart, they need open heart surgery. They can't have a stent because the stent might rough up the left main coronary artery. So you're deciding on medical therapy versus open heart surgery, a big decision, and you're looking at this angiogram and you really don't know, is that a 40, is it a 50, is it a 60% narrowing? You just can't tell. So you might do an IVUS using the ultrasound tip catheter, and you might see that what looked like a kind of a borderline narrowing is actually a large, ugly looking plaque, and you would say this person certainly needs open heart surgery. So they had 48 patients with narrowings in vessels that were somewhat ambiguous. They couldn't make up their mind, so they did the IVUS. In these individuals, they also did carotid IMT. So we're going to compare carotid IMT, coronary angiography, and the coronary IMT. Now, they do the coronary angiogram, and then they attempt to quantify it. You can use digital calipers on the coronary angiogram in an attempt to increase its precision. You'll do the IVUS of this angiographically borderline lesion and carry out certain parameters. You can actually measure the IMT of the coronary artery. And there's pretty much universal agreement that if the coronary IMT is above 0.6, that is a significant flow restrictive lesion. So that's the diagnostic criteria. They did the carotid IMT, they did the mean of the common carotid, the bifurcation, and the internal carotid, and overall mean and the highest of all these views. We're going to look at the correlation between the coronary angiogram, the carotid IMT, and the coronary IMT. Now, in the coronary angiogram, it was kind of borderline, roughly a 50% narrowing. If you apply the digital calipers to the coronary angiogram, calling this a quantitative angiogram, the group mean was 51%, but it was felt to be above 70% in 27% of the subjects and less than 40% in 33 of the subjects. So the digital calipers did seem to enhance the accuracy of the coronary angiogram within the limits of a coronary angiogram. On the coronary IVUS, the group mean vessel narrowing was 65%, showing that the coronary angiogram on average was underestimating disease severity. Then there's the various parameters of the carotid IMT. Now, correlation coefficients between the various carotid IMT parameters and the various coronary angiographic or IMT parameters are depicted on this slide. The greater the correlation coefficient, the tighter is the relationship. The correlation coefficient between the quantitative coronary angiogram and the different carotid IMT parameters was relatively low, 0.2 to 0.32. The correlation between the carotid IMT and some of the coronary IMT parameters was a little bit greater. If we look at the coronary artery IVUS IMT mean and the coronary artery IVUS IMT maximum, we have a much greater correlation, and a correlation coefficient of 0.5 is considered quite tight. The point here being the carotid IMT and the coronary IMT are measuring the same thing. They're measuring plaque. The coronary angiogram is measuring a silhouette. So if a study is done showing a not too tight correlation between carotid IMT and the coronary angiogram, that doesn't mean that the carotid IMT is not good. It really means that the coronary angiogram is wrong often, and that if we want to really do an apples to apples comparison, we would compare coronary IMT with carotid IMT, as they did in this study, showing a tighter correlation, because the IMT, the ultrasound measurements, are actually measuring plaque, soft plaque, which was what we are concerned about. It just confirms the diagnostic power, the accuracy of the carotid IMT study. Here we can look at the relationship between increasing carotid IMT and increasing percent narrowing on the angiogram. There's a lot of scatter. But if we look at the relationship between carotid IMT and coronary IMT, there's less scatter because it's an apples to apples comparison. Here we're going to look at the inaccuracy of the quantitative coronary angiogram and how we can improve upon that with the carotid IMT. Group C individuals had a fairly obvious 70% narrowing on their coronary angiogram, and their coronary IMT was above 0.6 in all. So if it's a 70% narrowing on the angiogram, it is a safe bet that that's significant, that you have a lot of soft plaque. Group B, they were 40 to 70%. Most of them had a high-grade narrowing, but some did not. Group A were felt to have a non-significant, less than 40% narrowing. You don't need any surgery or angioplasty. You're fine, go home. But when you do the coronary IVUS, you can see that many of them did have a high-grade narrowing, showing that the coronary angiogram can fool us. The coronary IVUS, which is measuring IMT, will be inherently more accurate. Here, we look at individuals with increasing carotid IMT, above 1 was the cutoff, and increasing coronary IMT above 0.6. So these people in the right upper quadrant had significant coronary disease, and they were predicted accurately by the high carotid IMT. The individuals in the white circles were those who were not felt to have a significant narrowing by the coronary angiogram, but many did have a significant narrowing. They were missed by the angiogram, and if you used the carotid IMT as an accessory measuring stick, you would have picked them up. This doesn't mean that everybody having a coronary angiogram must have a carotid IMT, but you can see that the greater the IMT, the greater is your risk in this and the prior studies of showing an obstructive narrowing. And the correlation between the carotid IMT and the real deal, the coronary IMT, the coronary soft plaque deposition, is quite tight. Predicting obstructive arterial disease with the carotid IMT. Again, it's not the percent stenosis that kills you. It is endothelial dysfunction, abnormal physiology that kills you. The angiographic percent stenosis is inherently inaccurate. The carotid IMT, which we're using as an outpatient procedure, correlates better with the coronary IMT than the coronary angiogram, because the IMT, the ultrasound measurements, are actually quantifying soft plaque, which is what we're concerned with. The coronary calcium score does correlate with plaque burden and risk. The carotid IMT is predictive of the coronary calcium score, the presence or absence of obstructive coronary disease, the number of vessels involved, and it has a stronger correlation with the coronary artery IMT, which is an accurate measurement of soft plaque deposition within the coronary arteries. Now we've discussed the use of IMT to predict the presence of obstructive disease, but I've said that obstructive disease isn't really what kills you. In the next section, we're going to look at the ability of the IMT to predict an adverse cardiovascular event, heart attack, stroke, or cardiovascular event. We've talked about the physics of IMT acquisition. We talked about normal or population expected and abnormal values. In the preceding section, we discussed the relationship between increasing carotid IMT and increasing degrees of coronary calcification and coronary soft plaque deposition. But I made a point that obstructive disease isn't really what kills you, it's the presence of abnormal physiology, endothelial dysfunction, with obstructive disease that causes cardiovascular events. If the IMT is the interface between physiology and anatomy, we should be able to use the IMT to predict our risk of a future adverse event, and that will be the subject of this section of our presentation. Here we're going to look at just over 5,000 Germans enrolled in the same health network where records were pooled and easily accessible to the researchers. Their average age is 50 with a wide range, 19 through 90. 2% had had a prior stroke, 2% had had a prior heart attack. At the beginning of the study, you look at their standard cardiovascular risk factors, diabetes, hypertension, smoking, etc., and the mean IMT of the common carotid artery. You're going to follow their course over 4 years. There were 385 events. The stroke rate was 5 persons per 1,000, or 0.5% per year. The heart attack rate was 1.1% per year. 50 died of any cause. We're going to correlate the IMT stratified by 25% brackets or quartiles with the 4-year event risk. We're going to look for interaction between IMT, age, and standard risk factors. The mean IMT for the group was 0.725. It was 0.65 in those who were younger, below 50 years of age, and it was 0.8 in subjects greater than 50 years of age. As you would expect, the IMT in all population groups increases with increasing age. Here, let's look at heart attack risk, event rate. In individuals whose IMT was below 0.63, the lower quartile, the heart attack rate was 1.6%. Those in the second quartile, the heart attack rate's 3%. In the third quartile, it's 4%. In the fourth quartile, it's 9%. If you look at relative risk for having a heart attack, being in the fourth quartile versus in the first quartile, you're 6 times as likely. Now, if you adjust for age, gender, and risk factors, the relative risk is attenuated, but you're still twice as likely. If we look at the stroke event rate in the lower quartile for IMT, it's 0.4% per year. In those in the upper quartile, it's 5% per year. You're 10 times as likely to have a stroke if you're in the upper quartile versus in the lower. Again, if you adjust or correct for differences in age and risk factors, the relative risk decreases, but it's still highly significant. On this slide, we're going to look at heart attack, stroke, or death. In the lower quartile, it's 2%, pretty low risk. In the upper quartile, it's 14%. You have your reports in front of you. You could plug your numbers into this study to predict your own risk of having an event. But of course, this data applied to a wide age range, and the relative risk of an 80-year-old will be greater than that of a 40-year-old irrespective of the IMT, because with increasing age comes increasing risk. Here, if we stratify the subjects by increasing age, the average age was 50. So the first quartile is probably people below age 40. The second quartile is 40 to 50. The third quartile is 50 to 65. The fourth quartile is probably above 65. They didn't actually give us those numbers. I'm giving you an estimate. You can see that in the more senior subjects, the risk rises with increasing IMT, and the same in the younger or the middle-aged individuals. The relative risk of a high IMT, your risk relative to your age-matched peers, is quite high in the first and second quartiles, because overall risk is relatively low in young people. But still, in all age ranges, your IMT increases your risk. If we divide the IMT into quartiles, lowest versus on the left versus greatest on the right, and then we plot increasing age and risk, whatever your IMT is, the older you are, the greater is your risk. And increasing IMT increases risk. Increasing age, of course, increases risk. And there's an interaction here. In this slide, we're going to plot increasing age and increasing IMT. High IMT, high age, increased risk. Low IMT, low age, less risk. So there's an interaction here. So when we're looking at your individual IMT value and assessing risk, we must keep your age in common. If you have a IMT at the 90th percentile for a 40-year-old, that's bad. You're at much greater risk of having a heart attack than a 40-year-old with a lower IMT, but your absolute risk is still quite low because you're only 40. So we want to keep in mind age when we're calculating risk associated with a given IMT value. Another study of IMT and 6-year risk of stroke. Just under 7,000 residents of Rotterdam in the Netherlands recruited from the general population. They're all at least 55 years of age, none with a prior stroke, but they all had risk factors. A third were hypertensive, 10% diabetic, 23% were smokers, 12 had a prior heart attack, 24% had known cardiovascular disease. So this is a general population of individuals above 55 years of age, many who have risk factors, many who have cardiovascular disease, and this is a population typical of the patients who might see me. At study entry, you're going to look at the standard risk factors. You're going to do the common carotid artery mean IMT. You're going to follow them for 6 years. And 378 of the 6,913 subjects sustained a stroke. You're going to first stratify their IMTs by tercile, first, second, and third. And you're going to look at stroke risk. Those who were in the lower tercile, below 0.72, their stroke risk was 2%. Those in the middle tercile, it's 5%. Those in the upper tercile, it's 9%. That's a pretty high stroke risk in the general population. You can take your own numbers, and if you're above 55 years of age, plug yourself in and predict your stroke risk. Individuals in the upper tercile were over 2 times as likely to have an event as those in the lower tercile. The Rotterdam study also looked at stroke risk in association with carotid plaque, visible plaque, aortic calcification, the ankle brachial index, which reflects poor blood flow to the lower extremities, and their interactions with standard risk factors. And the risk factors weren't really predictive. The only measurements that were predictive were the carotid IMT and aortic calcification. They were the most important predictors of who was going to have a stroke, and this makes sense because the IMT is the staging ground for obstructive plaque. IMT is predictive of cardiovascular disease. Obstructive plaque in the great vessels, in the carotid arteries, and in the heart are all associated with an increased risk of stroke. The Cardiovascular Health Study Collaborative Research Group looked at the interaction between IMT and heart attack and stroke risk in seniors. 4,476 Medicare beneficiaries free of known cardiovascular disease. At the beginning of the study, you look at standard risk factors. You do the mean maximal IMT of the common carotid and the internal carotid. You're going to follow their course over 6 years. 496 of the subjects, roughly 10%, had a heart attack or a stroke, which is what you would expect from a population of Americans above 65 years of age. Let's correlate their IMT at baseline with 6-year event risk. Look for interactions between the IMT and the standard risk factors. Here we're going to stratify the IMTs into increasing quintiles and look at 6-year event-free survival. Those in the first quintile, not too many events. Those in the 5th quintile, 25% had an event. If we look at 6-year heart attack or a stroke risk versus the common carotid artery, mean maximal IMT, if you were in the lower 20% bracket, your event risk is only 5%. If you're in the upper quintile, above 1.18, your risk is 19%. So if you're coming in to see me and we're concerned about your risk, and we need to decide how aggressive we need to control your risk factors, I'm going to do your IMT. And if it's low, I can say your risks of getting into trouble are not great. If it's high, if you're above 1.18, I can say, heck, you got a 20% chance of having a major event. We need to work quite diligently. Here we can look at yearly heart attack and stroke risk versus the increasing quintiles. So if you are in the lowest 20% bracket, below 0.87, and you can look at your own report and see how you plug into here, your yearly event risk is only 1%, not bad. However, it's 3% if you're in the 5th quintile. If you're in the 5th quintile, you're 4 times as likely to have an event compared to your colleagues who are 65 years of age or older that have a low IMT. This shows the predictive power of the IMT in predicting not just the presence of obstructive disease, but predicting events, which is what we really care about. 6-year heart attack risk, 6-year stroke risk, you can break it down, same relationship. Increasing IMT, increasing risk of stroke or a heart attack. Data from the ARIC study, the Atherosclerosis Risk and Community Study, here we're going to look at Americans age 45 through 64, younger than in the CHS study. They were all free of known cardiovascular disease, residing in different communities throughout the United States. We're going to look at the mean common carotid IMT, standard risk factors, follow them for 4 to 7 years. 290 had a heart attack or a cardiovascular death. 392 had a cardiovascular event or needed a revascularization. Now, of the men without events, they tended to have lower IMTs than the men with events. Same relationship, although not as tight with women. That all makes sense. The 4 to 7 year heart attack cardiovascular death rate for men, again, age 45 through 64, those with lower IMTs, the event rate was 3%. As your IMT increases, if it's above 1, this is the mean common carotid IMT in someone 45 through 64, the event rate is 13%. Similar relationship for women with a higher relative risk when the IMT rises above 1. If you adjust for age, gender, location, lipids, weight, other risk factors, there's still a significantly increased risk if you have a high IMT. If you have an IMT above 0.8, you're in the 4th or 5th quintiles as compared to your next door neighbor with a low IMT, you're well over 2 times as likely to have an event. In women with a IMT above 1, it's particularly malignant. You're 7 times as likely to have an event as opposed to your neighbor with an IMT below 0.6. Here we can graph event rate as a function of increasing IMT. Your risk increase per standard deviation, a statistical term here, a 0.19 millimeter increase in IMT as compared to your colleague. In men, that increases your risk by 17%, in women by 38%. Here, let's look at a sicker population. IMT is a risk marker in hypertensives with coronary disease. 297 consecutive hypertensives referred for coronary angiography. Those would be the type of patients that I might be taking care of. 46% with a prior heart attack, 40% prior revascularization, all on antihypertensive therapy, 2/3 on lipid-lowering therapy. These are people with hypertension receiving modern-day medical therapy. You'll look at their standard risk factors, you'll do the carotid IMT, you'll do coronary and renal artery kidney angiography, and their cutoff was 1.13 separated high from low risk IMT. You're going to follow their course over the following 3.5 years looking for mortality, heart attack or stroke. We're going to correlate the IMT with future outcome. First, let's look at the ability of the IMT to predict the presence and extent of coronary disease. Those with non-significant disease, their IMT was 1.05. Those with one vessel disease, it's 1.16. As the IMT increases, the extent of the coronary disease increases, as in our prior studies. If we want to predict risk of death from the baseline data, if you correct for all the interactions between the risk factors, if you do a multivariate analysis, the predictors of death were the number of vessels blocked and a high IMT. Individuals who had a high IMT above 1.13, you can see that event-free survival was not so good. 25% died. However, those with a relatively low IMT, 99% survived at 6 months versus 78% with those with a high IMT. So if you have high blood pressure and there's something about you that prompts you to do an angiogram, and I do an IMT, from the IMT I can predict the future with a great deal of accuracy. I can predict who's going to get into trouble and who is not, here for risk of death. If we look for risk of cardiovascular event, revascularization, unstable angina, heart failure, all events exclusive of death, the predictors were IMT and diabetes. If the maximal IMT was below 1.13, 99% event-free survival at 20 months, 95% at 6 months. High IMT, 95% event-free survival at 20 months, only 74% at 60 months. So the IMT will tell me how hard we need to work with you to control your risk factors. It will clearly predict who's going to get into trouble, who's likely to die. Now, here, in these prior studies, we looked at the IMT at one point in time to predict the future. I've stated that if we change your risk factors, if we improve your physiology, we can change your IMT. In this study, let's look at change in IMT over time as a predictor of events in the future, because if you're working with me, we're going to want to change your IMT. If we work hard and stabilize or regress your IMT, lower your soft plaque burden, will you be rewarded with relative protection against adverse events in the future? That's the reason that we do risk factor reduction. 146 men, aged 40 through 59, none were current smokers, all had prior bypass surgery. So these are individuals with well-established cardiovascular disease, stable following bypass. Baseline studies, you do a coronary angiogram in a non-bypass vessel, and you measure the mean IMT of the common carotid artery. You're going to randomize them to 2 years of lipid-lowering therapy versus placebo, drug therapy versus placebo therapy. You're going to repeat the baseline studies periodically. The IMT you're going to do every 6 months over a 2-year period. You're going to repeat the coronary angiogram 2 years into the diet plus or minus drug therapy program. Then over the following 9 years, you're going to look for cardiac events, and 47% had an event, as you would expect in men that had already required open heart surgery. You'll correlate their status at 11 years out with baseline coronary percent narrowing and 2-year change in coronary percent stenosis, and baseline carotid IMT and 2-year change in carotid IMT. 9-year event rate, 47% for the group, as you would expect. 3% died, 19% heart attack, 14% had a repeat bypass, 10% required a balloon angioplasty. Now, let's look at the baseline coronary narrowing at the beginning of the study and 9-year risk. It was 35 to 37% in all of them, whether you had a heart attack or died or you didn't, whether you had a coronary event or you didn't. So the baseline percent narrowing was not predictive of your risk over the following 9 years. Let's look at the change in coronary artery percent stenosis over the 2 years of diet plus or minus drug therapy. Those who subsequently had a heart attack or died, they progressed by 4.2% over 2 years. Those who did not have a heart attack or died progressed by only 0.7%. Those who had an event progressed by 3.8%. Those who did not have an event did not. So if your coronary angiogram, measured as precisely as possible, does not show progression, you're not going to have an event. So the change in physiology brought out by diet changed the rate at which plaque built up in the coronary arteries. Those whose coronary arteries progressed over 2 years were more likely to get into trouble over the next 9 years. Those whose coronary arteries were stable enjoyed a relative freedom of adverse events. But then again, you got to do the coronary angiogram every 2 years, and the precision of that measurement is not great. Let's look at the baseline common carotid IMT versus 9-year event risk. Those who did not have a heart attack or death, were really no different from those who did. Those who had an event was no different from those who did not, because this is baseline prior to any intervention. Now if we look at the peak 2-year IMT, the result of 2 years of diet with or without drugs, and 9-year event risk, those who did have a heart attack or a death, their peak level was 0.7. Those who did not, it was 0.64. Those who had an event, 0.69. Those who did not, with 0.63. Now their average carotid IMT was about the same at the start, but the peak levels are different because some progressed their carotid IMT, some did not. If we look at baseline IMT versus 9-year event risk, it's not predictive. The peak IMT is quite predictive. It's the change in IMT over the 2 years of active intervention. Those who had a heart attack or a death progressed at 16 points per year, 16 micrometers per year. Those who did not die or have a heart attack actually regressed 8 points per year. Those who had an event progressed 14 points per year. Those who did not regressed 15 points per year. So if we can stabilize or regress your IMT, something that is very easy to measure without any risk, we can provide relative protection against events over the next 9 years. Small, subtle changes in the IMT are quite powerful and predictive of your future event rate. So our goal is going to be to stabilize or regress your IMT, for if we do that, we can provide you relative protection. Here, we're going to look at 9-year risk of events versus the 2-year change in your IMT. If you progressed less than 11 points, your heart attack risk was 2%, your event risk is 4%. If you progressed above 34 points per year, your heart attack risk is 5%, your event risk is 20%. So we want to stabilize your IMT, preferably regress it. For if not, if it's progressing rapidly, you're much more likely to get into trouble. So your IMT at any one point is predictive of future event rate. A more powerful predictor is the rate of change of IMT. Because if your IMT is progressing rapidly, your soft plaque factory is at full throttle, you're going to make large plaque, and you're more likely to have an event. Another study using IMT to predict risk in cardiovascular patients. This is the SMART study carried out in Europe. You're going to look at 2,374 Dutch subjects with known cardiovascular disease. And it wasn't just one vascular circuit involved. Of the 1,158 patients that had coronary disease, 134 had had a stroke or a TIA, 84 had an abdominal aortic aneurysm, 6 had renal artery narrowings, and vice versa. You're going to do the carotid ultrasound, you're going to look at the mean carotid IMT and the presence of plaque, which they define as a focal bulge in IMT above 2 millimeters. Follow their course over 3 years, correlate event rate with baseline findings. 9% of the subjects experienced at least one event, 5% died. The common carotid mean IMT ranged from 0.36 to 4.52 with a mean value of 0.95. Your event risk, your relative risk of having an event per standard deviation change in the IMT, and this was 0.32 millimeters, for every 0.32 millimeter increase in IMT relative to the rest of the population, 9% of the subjects experienced at least one event, 5% died. The mean common carotid IMT ranged from 0.36 to 4.52 with a mean or group average of 0.95. Let's look at your relative risk of having an event per increasing IMT. They used one standard deviation, which was 0.32 millimeters. So within the total population, which is in blue, if your IMT is 0.32 millimeters greater than that of your next door neighbor, your risk of an event rises by 30%. Your risk of stroke by 40%. If you look at individuals who did not have high-grade disease, whose IMT was below 2, lower risk individuals, if your IMT rises by 1 standard deviation, your relative risk increases. The relative risk of an increasing IMT is greater in individuals who otherwise would be at lower risk. If we look at relative risk per disease category, with increasing IMT, the individuals with coronary disease were not just at risk for more cardiovascular disease, they were also at risk for stroke, coronary event, all events. Those with peripheral vascular disease were not just at increased risk for more peripheral vascular disease, they were at increased risk for stroke and cardiovascular death and coronary event, because we're talking about your diathesis to vascular disease in general. Rarely will vascular disease be confined to one circuit. So as your IMT increases, this is reflecting increasing soft plaque burden throughout your body. As your soft plaque burden throughout your body increases, it makes sense that your risk of a heart attack, peripheral vascular disease, renal compromise, and stroke will increase. It's all one and the same. Now let's look at the interaction between IMT, a measure of anatomy. Now it's the interface between physiology and obstructive plaque, but it's still an anatomic measurement. And let's also link risk associated with IMT to risk of inflammation as measured by C-reactive protein. We all know that inflammation plays a role in cardiovascular disease and precipitating cardiovascular events. The best characterized marker of inflammation is the CRP or C-reactive protein. 5,417 men and women above 65 years of age, an elderly group of mean age of 80, no prior stroke, no cardiac arrhythmia that would increase the risk of stroke, such as atrial fibrillation. Look at standard risk factors. You're going to do the IMT, the mean maximal of the common and the internal carotid. You're going to look at CRP. Record stroke rate over the ensuing 10 years. Nearly 9% experienced a stroke. The yearly stroke rate was 1.1% in men. That's 11% over 10 years. It's slightly less, 0.97% per year, or 9.7% risk over 10 years in women. We can look at the baseline characteristics of those who did have a stroke, those who did not have a stroke, and those that had strokes were more likely to be diabetic, hyperlipidemic, have high cholesterol, etc. But there was an interaction between C-reactive protein and 10-year stroke risk. Individuals that had lower C-reactive proteins in the first quartile below 1.1, their 10-year stroke risk was 8.2. As your C-reactive protein increases, if you're in the fourth quartile before 0.3, your 10-year stroke risk is now 14%. The relative risk of a stroke with increasing CRP, if you're in the second quartile as opposed to the first quartile, your risk rises by 30%. In the fourth quartile, it rises by 80%. So rising CRP is associated with an increased risk of a stroke. Let's look at the risk increase per quartile of CRP as a function of the IMT tercile. Individuals with lower IMTs, the lower tercile, the lower third, per incremental increase of CRP, your risk rises by 3%. Those with mid-range IMTs, for the same incremental increase in CRP, your risk rises by 5%. Those with the thickest IMTs, the greater soft plaque burden, for the same incremental increase in CRP, your risk rises by 8%. The CRP as a stroke risk predictor doesn't matter as much if the IMT is low. The CRP matters a lot when the IMT is high. Stating that in common language, if your arteries are clear and there's no soft plaque, and you have inflammation, that's not going to hurt you nearly as much as if you have inflammation in the presence of a high degree of soft plaque. Inflammation plays a role in the generation of plaque, but it really plays a role in precipitating events. Inflammation puts vulnerability into plaque. If you have individuals with comparable degrees of plaque that is significant, one is inflamed, one is not, the inflamed patient is the one who's going to destabilize and have an event. So inflammation is particularly malignant in individuals with a greater burden of fixed disease of soft or hard plaque. So if your CRP is high and you're 35 years old and your arteries are okay, I know you're not going to have a heart attack or a stroke in the near term. I want to work with you on your risk factors. However, if you're 80 years old and you've got significant high-grade obstructive disease and your CRP is high, I know that that inflammation is particularly malignant. We need to work diligently to control your risk factors and control inflammation. A similar analysis was done at predicting heart attack and all cardiovascular event rate in seniors. The greater the anatomic disease as predicted by your IMT, the greater is your relative risk of an event as a function of inflammation. There's a synergy between anatomy and inflammation as measured by the CRP. Let's look at IMT versus Framingham risk factor analysis. Can we use the IMT to clarify intermediate risk status? Now, a skeptic might say, why you bother doing this IMT? We can just look at old-fashioned risk factor assessment to predict your risk. What if we just look at blood sugar, blood pressure, smoking? Can't we predict risk with those traditional values? Is the measurement of IMT going to provide incremental predictive information to justify its use? Let's say we want to be cost effective. Is it worth it to do an IMT? Here we're going to look at the first 200 subjects to undergo IMT testing at the University of Michigan. Now you're going to calculate their Framingham risk scores by their number of points and stratify them into low risk, less than 5% risk over the next 10 years, intermediate and high risk based on their conventional risk factors. Then you're going to carry out IMT testing of the common carotid artery. In the methodology section, they didn't say whether this was mean or maximal. I think it was mean, but I couldn't tell from the article. Low risk was an IMT below 0.8, intermediate was 0.8 to 1.0, high risk was above 1 based upon their own University of Michigan criteria. So we're going to compare the IMT risk versus the calculated risk in Framingham intermediate subjects. 95 of the subjects were at intermediate risk by Framingham. If we look at their IMT, is that going to help us stratify these individuals into, could they perhaps be high or were they really low risk? Would the IMT help us predict who's likely to get into risk, which individuals should we focus on with risk factor reduction? Now, if we look at the IMT predicted risk in the individuals who were kind of intermediate by standard risk factor analysis, 44% were actually low risk. They had an IMT below 0.8. 34% were still at intermediate risk, but 22% of those who were not felt to be at high risk by standard risk factor assessment really had a high soft plaque burden. 2/3 of the subjects were reclassified more accurately based upon their IMT assessment. And this makes sense. I stated that the more risk factors you have, the greater will be your IMT. But the Framingham data just looked at a handful of risk factors. Every year we're learning new causes of cardiovascular disease. And in our subsequent presentations, I'm going to give you some risk factors you've never heard of, like lipoprotein A or homocysteine or bacterial infection or adiponectin. The IMT reflects the sum total adverse effects of all your risk factors Those we know and those we don't know about because it's actually the disease itself. The Framingham Risk Factor Assessment is looking at the risk factors that we've known about for 20 years. We're not interested in numbers, we're interested in the disease itself that we can measure with IMT. So of course, predicting risk based on IMT is going to be inherently more accurate and useful than predicting risk based on a list of numbers. Using the IMT to predict event risk, take your report right out in front of you and plug yourself in. We can look at heart attack, stroke, cardiovascular event, and death risk, and we can see that it rises continuously with IMT. Plug yourself into the studies, but be careful to plug yourself into a study in which you could have participated. If everyone in the study was above 65 years of age and you're 45 years of age, that prognostic data does not apply to you. So plug yourself into a study appropriate for your age and clinical condition. The absolute risk with a high IMT rises with advancing age and pre-existing cardiovascular disease. The older you are, the sicker you are, the greater is your risk of having an event independent of the IMT. The younger you are, the lower is your short-term absolute risk for having an event at any given level of IMT, which is why when we're looking at your risk with IMT, we're going to only plug you into the studies corresponding to your age range. Inflammation is far more malignant if your IMT is elevated. The IMT provides predictive information above and beyond that of carotid plaque status and risk factor analysis. IMT integrates the deleterious effects of all your risk factors to look at your soft plaque burden. The IMT is the staging ground for future plaque and future events, so we feel that the IMT is the best predictor of your future risk of an adverse cardiovascular event. Now, we can plug ourselves into these two tables. If you are an American without known cardiovascular disease, age 45 through 64, you can plug yourself in to this chart based upon your mean common carotid IMT and look at your risk via, if you're a man or a woman, of heart attack or cardiovascular death over the next 6 years. If you are a senior above 65 years of age, you can look at your mean maximal common carotid IMT and predict your risk of heart attack, stroke, or a composite. And this is what we're doing with our patients. So then we know who needs the most work, who is not at great risk. And if you're not at great risk, then I don't need to give you potentially dangerous medications that are expensive or have side effects. Yet, if your risk of having an event over the next 6 years is 20%, I'm going to push and shove and twist your arm to take all the medicines that I think you need. I'm going to tell you to tough out the side effects because without aggressive work, you're going to be in big trouble. So this is how the IMT can really help us in clinical integrative medicine. Now we'll move on to the next section, talking about the influence of hormones. Thyroid hormone in both genders, testosterone in men, and estradiol in women on IMT and IMT progression. In this section, we'll discuss hormonal influences on the carotid IMT value. We'll start with thyroid status. Hypothyroid, that is the thyroid hormones T3 and T4 are low. TSH, that's thyroid stimulating hormone, the hormone made by the brain to tell the thyroid to work harder, that would be elevated. Hypothyroid status is associated with hypolipidemia. Your LDL cholesterol is high, your lipoprotein little a is high, and all agree that individuals who are hypothyroid are at increased risk for cardiovascular disease and an increased risk for cardiovascular disease progression. So we will make sure to check your thyroid and treat you because we don't want you to be hypothyroid. There's a condition called subclinical hypothyroidism, which until recently was associated really with controversy. Your T3 and T4 are still normal, but the brain's not happy with the situation and it's making TSH. Should we treat you or not? Well, one group says, hey, the T3 and T4 are still within normal limits. We don't need to treat the patient. Another camp will say, well, the brain's not happy with the situation. The brain's smarter than us doctors. If the brain is telling the thyroid to work harder, we should supplement with thyroid. So there's sort of a controversy between these camps. Do we treat subclinical hypothyroidism or not? Do we treat well before the patient is obviously hypothyroid, hypometabolic, tired, fatigued, low heart rate, dry skin, high cholesterol, constipation? Now, in the 1940s, before we had modern day drug therapy and coronary angiography, a routine treatment for angina was thyroid replacement. It didn't matter what your thyroid chemistries were, they would treat you with very low dose thyroid replacement and slowly increase the dose. The idea being that you were hypometabolic, you were not burning up your cholesterol, it was laying out in your arteries, so they would start with a very low dose of thyroid and gradually increase you up to 5 grains per day, which is a relatively high dose. And the patients did great. I pulled those articles, I read them, the patients indeed did great with slowly escalating doses of thyroid. Well, if 5 grains of thyroid worked, and it took you a year to get there, well, heck, let's just start the patients off at 5 grains. Let's be expeditious about it. Well, that was a disaster because it was a shock to the system. If I gave you thyroid and you really didn't need it, and I gave you a low dose, your brain would sense it and it would stop making TSH to tell the thyroid to work. So I wouldn't make you hyperthyroid, I wouldn't make you sick, because your brain would have a chance to throttle down. But if I just gave you a whopping dose of thyroid all at once, you could have a thyroid storm and be hypermetabolic, your heart rate and blood pressure goes up, so of course those patients might have heart attacks. So thyroid was effective if given slowly and working its way up. Then some people who really didn't think things through gave large doses of thyroid and precipitated heart attacks. So thyroid replacement got a bad name. And in medical school, we were advised against thyroid replacement. We were basically advised wrong. Now, many physicians feel that subclinical hypothyroidism should be treated. The patient looks hypothyroid, they act hypothyroid. Even though their numbers are okay, you treat them and they get better. And indeed, that is the case. And more studies are coming out showing that an ideal TSH may be relatively low. So there's sort of a meeting of the minds here. The conventional wisdom is still do not treat with thyroid unless the TSH is high, but the criteria for a high TSH is falling. So both groups gave a little bit and were being a bit more liberal with thyroid replacement. And I think that's in the best interest of our patients. Now let's specifically look at IMT in subclinical hypothyroidism and the effect of thyroid replacement. If subclinical hypothyroidism is really that big a deal, we would expect that it might be associated with an increased IMT. Let's take a look. 77 Italian subjects, none with diabetes, hypertension, none were above 55 years of age, none were smoking. They didn't have a lot of risk factors. 45 had subclinical hypothyroidism. Their T3 and T4 hormones were normal, but the TSH was high. The brain's saying, hey thyroid, you're not getting the job done, I want you to work a little bit harder. Then the control group, 32 age, gender, and body mass index weight matched controls. You're going to measure their lipids, do the carotid IMT. Then those who are subclinical hypothyroid, you're going to randomize them to thyroid replacement therapy with synthetic T4, levothyroxine, starting at a very low dose and gradually increasing until the brain is satisfied that there's enough thyroid. The other hypothyroid patients receive placebo. And you're going to repeat the baseline measurements at six months after the target TSH has been achieved in the drug therapy group. Now, here are the controls. Here are the subclinical hypothyroid. You can see that the T4 and T3 levels are a little bit greater in the controls than those with subclinical hypothyroid, but they're still all within normal limits. The TSH is high in the subclinical hypothyroids. The T4 and T3 are okay, but the brain's not happy. It's saying, thyroid, I want you to work harder. Those with subclinical hypothyroid, you can see their cholesterol is higher, 214 versus 185. Their LDL is higher, 138 versus 114. Their lipoprotein A is higher, their homocysteine is higher. So subclinical hypothyroid is associated with an adverse lipid and risk factor panel, not a good thing. The mean IMT of the control subjects is 0.63. Those of the subclinical hypothyroid match for age, absence of diabetes, absence of smoking, absence of high blood pressure. The only difference is the subclinical hypothyroid, look, they're much higher at 0.75. Now that relative difference in IMT is associated with a huge future risk of cardiovascular disease. The maximal IMT was also significantly greater in the subclinical hypothyroid patients. The only difference is subclinical hypothyroid causing a significant incremental increase in the IMT. Okay, so we have these individuals with subclinical hypothyroidism and a relatively increased IMT. Half get replacement therapy, half do not. With replacement therapy, the TSH falls from 6 to 1.3, the T4 and the T3 rise a little bit, and their cholesterol falls, their LDL falls, their triglycerides fall, their homocysteine, their LPA falls. So if you give them just a little bit of thyroid, their risk factor panel improves within a year. If you look at the mean IMT of the subclinical hypothyroid patients who did not receive thyroid replacement, they progressed by 30 points over a year. Those that received thyroid therapy fell dramatically by over 100 points, from 0.76 to 0.67. That is a huge interval improvement in IMT, greater than that can be achieved with any other methodology. The maximal IMT continue to progress in those on placebo therapy. This subclinical hypothyroidism is a pretty bad thing. Those that were given replacement therapy improved by 100 points. So treating subclinical hypothyroidism improves the risk factor panel and has a dramatic regressing effect on soft plaque deposition of the neck, as evidenced by the mean and the maximal IMT. So subclinical hypothyroid is associated with increased lipids, increased carotid IMT. In other studies, in individuals who everybody would agree has relatively normal thyroid function, the higher your free T4 within the normal range, the less plaque you have. So we don't want just okay thyroid function, we want high normal thyroid function. That's associated with relative freedom of cardiovascular disease. In subclinical hypothyroid patients, thyroid replacement lowers the lipids, lowers the homocysteine, lowers the lipoprotein A, and decreases IMT. How does thyroid replacement help? Well, it lowers lipids, it normalizes overall thyroid function, both, and there may be other factors involved. Now, here's another study, 66 Italian women in overall good health, 40 with newly diagnosed subclinical hypothyroidism, normal T3, T4, high TSH, 20 age and weight match controls. Baseline measurements, thyroid chemistries, lipids, IMT, and then you're going to randomize the subclinical hypothyroid patients to receive levothyroxine. They're hypothyroid, let's give them thyroid. In another group, you left them relatively hypothyroid, but you gave them simvastatin, a statin lipid-lowering agent, which is going to have the most powerful protective effect on IMT. You're going to repeat the lipid panel and the IMT at 8 months. The mean IMT in the controls was 0.54. It was 110 points higher, 0.66, in those with subclinical hypothyroid, consistent with the prior study. Now, in the individuals who were treated with simvastatin, which is the generic name for Zocor, there's no change in their TSH or their thyroid. Their LDL fell dramatically from 134 to 103. as you would expect with statin therapy. In the subclinical hypothyroid patients that were treated with thyroxine, there wasn't a major change in their cholesterol, although their thyroid parameters improved. The TSH fell from 10.9 to 2.0. So lipid reduction doesn't affect thyroid, it lowers lipids. Thyroid replacement did not have a major effect on lipids, but it normalized the thyroid situation. In both groups, the mean IMT fell significantly in a short period of time. With simvastatin, it falls from 0.67 to 0.58. With thyroid replacement, from 0.66 to 0.55. So if you are low in thyroid and we fix the thyroid, we're going to regress plaque. If for whatever reason we don't want to treat your low thyroid and we give you a statin drug, we're going to regress your plaque. I kind of think this is an irrational concept. If someone has a physiologic aberration, they're low in thyroid, you should give them back what Mother Nature intends them to have as opposed to giving them a drug. But the purpose of this study was to show you could improve IMT either by improving thyroid function or by using a drug to lower cholesterol. Or we could actually use both because we are not going to be confined to a drug approach versus a nutritional approach alone. In medical school, I was taught that testosterone caused or aggravated cardiovascular disease, and that is entirely wrong. In men with known cardiovascular disease, testosterone replacement therapy is of universal value, and there are 50 studies that show this. My typical new male patient with established cardiovascular disease has a low or low normal testosterone. Testosterone replacement therapy is of value. It will give you an extra minute on the treadmill. It will decrease angina frequency. So testosterone replacement therapy in men with known cardiovascular disease is of accepted value. Here we're going to talk about testosterone and IMT. Now in men, low testosterone or an elevated estradiol is associated with insulin insensitivity and diabetes, overweight status, low muscle mass, vascular inflammation, a tendency to clotting, increased blood viscosity, your blood's like ketchup and not wine, increased risk for stroke and heart attack. Testosterone levels are lower in diabetic versus non-diabetic men. Diabetics with low testosterone at increased cardiovascular risk. Diabetics with elevated IMT are at increased risk. Here let's look at the interaction between testosterone status and IMT in diabetic men. 154 Japanese diabetic men. We're going to look at the standard risk factors. We're going to measure total and free testosterone. We're going to do a carotid ultrasound looking at the mean IMT of the common carotid bifurcation of the internal carotid and the presence or absence of plaque. We're going to correlate testosterone and standard risk factors with the IMT findings. The group mean free testosterone was 10.8, which is the lower limits of normal. Free testosterone was inversely related to IMT and plaque score. The lower the testosterone, the greater the IMT, the greater the plaque score. Here we have decreasing testosterone correlates with increasing IMT on the left. On the right, we can see that as the testosterone level falls, the plaque score is greater. If you defined a low free testosterone as below 10, you can see that the plaque score and the IMT is greater in the men with low testosterone versus the higher testosterone. Testosterone, estradiol, and IMT progression. We make testosterone in our testicles. It can be converted to estradiol by an enzyme called aromatase. We find aromatase in belly fat. So as we gain weight, especially in the belly, we convert an increasing amount of our testosterone into estradiol. Testosterone is protective, while estradiol is causative of cardiovascular disease. This is one of the problems of overweight stature. As we age, we make less testosterone, but if we're overweight as we age, the testosterone that we do have is converted into estradiol. Here we're going to look at 195 Dutch men above 70 years of age, look at standard risk factors, testosterone and estradiol, and mean common carotid IMT as we would measure in the office. You're going to repeat the IMT at 4 years. Now the mean IMT increased over 4 years from 0.96 to 1.09 millimeters for the group. That's 130 points over 4 years, or 32 points per year. And that's a high rate of progression, but again, these were older men than in the ARIC study where the yearly progression was 10 points. Let's correlate hormone levels, testosterone and estradiol, with the rate of IMT progression. Now, let's look at 4-year progression rate versus testosterone tercile. The men in the upper tercile, the upper third for testosterone, the top slide, free testosterone, the bottom slide, did not progress very rapidly, 20 points per year. Men in the lower tercile, the lower third for total testosterone and free testosterone, progressed rapidly. So low testosterone is associated with an increased rate of IMT progression. Conversely, the greater your estradiol, the greater was your rate of progression. So low testosterone, high estradiol, we don't want to see that. That's associated with an increased risk or increased rate of IMT progression. Anything that increases your rate of IMT progression is going to increase your rate of an adverse cardiovascular event. Estrogen in women. 222 postmenopausal women, 45 years of age or older, with an LDL cholesterol above 130. That's not dangerously high, but it's above the desirable range. None with known cardiovascular disease. None were on hormone replacement therapy or experiencing obvious estrogen deficiency symptoms. Baseline assessment, you're going to look at the mean common carotid IMT lab studies. You're going to put them all on the American Heart Association low cholesterol, low fat diet, and lipid-lowering drug therapy if their LDL was above 160. Then you're going to randomize them to micronized estradiol. This is the same, it's a bioidentical estradiol, the same molecule that a woman's ovary makes, or placebo. You're going to repeat the IMT measurement every 6 months over 2 years. What happened? If we look at all subjects, here's the placebo therapy, estradiol therapy. With estradiol, the cholesterol fell a little bit more, 8% versus 6%. The LDL fell a little bit more, 16% versus 10%. HDL improved a little bit more, 14% versus 8%. Insulin levels fell a little bit more. We want low insulin levels. So estradiol therapy had some beneficial biochemical effects. If we look at the women who had high LDL cholesterols above 160, who received lipid-lowering therapy, the relative effect of estradiol on lowering the cholesterol and the LDL was blunted. Estradiol and lipid-lowering therapy lowered the LDL by 20%. Lipid-lowering therapy alone lowered it by 15%. So lipid-lowering therapy lowers the cholesterol. Estradiol lowers the cholesterol. The combination lowers the cholesterol even more. Beneficial effects on the risk factor panel. But we're really interested in IMT. If we look at all participants, those on placebo progressed at 3.6 points per year, a fairly low rate of progression, but those on estradiol regressed. Menopause is associated with a relative increase in the rate of IMT progression in women, as you can see in the placebo group. But with hormone replacement therapy, there was no progression, there was actually regression. If we look at the women not on lipid-lowering drug therapy, so it was just placebo versus estradiol, the women in the placebo group progressed much more rapidly, 13 points per year. The women on estradiol still regressed. There was a greater difference because the lipid-lowering drug therapy kind of diluted out some of the beneficial effects of the estradiol. In the women with an LDL below 130, they progressed at 13 points a year, but if they received estradiol, they actually regressed. So lipid-lowering therapy was helpful, estradiol was helpful as well. Of the women on lipid-lowering drug therapy, they regressed in both groups, but they regressed more with estradiol. So there was some additive benefit of adding estradiol to lipid-lowering therapy. And you get the other benefits of hormone replacement therapy above and beyond the vascular benefits. if we look at the 2-year change in IMT, with placebo alone, you're progressing 13 points per year. With estradiol alone, you're regressing 1.3 points per year. Drug therapy alone, you're regressing 1.6 points per year. Estradiol and drug therapy, 1.9 points per year. So while the popular press has vilified hormone replacement therapy in women, if you give bioidentical hormone replacement therapy to women early in menopause, a situation associated with inflammation and rapid disease progression, there's a benefit. We must say in the studies that made hormone replacement therapy look not so good, there are 2 flaws. First of all, they began hormone replacement therapy 10 years after menopause. The inflammation already occurred. The treatment was really inappropriate. It was too late. That didn't make any biological sense. And they used Premarin and Provera. Those are not bioidentical hormones. Those are man-made hormones that have unique toxicities above and beyond that due to estradiol. So pharmacologic hormone replacement therapy given late after menopause isn't too bright an idea, but bioidentical hormone replacement therapy begun at the appropriate time in this study was of benefit. Raloxifene, inflammation, and IMT progression. Raloxifene is a selective estrogen receptor modulator. It will bind the estrogen or estradiol receptor and block many of the deleterious biochemical effects of estrogen deficiency without affecting hot flashes. And some people feel that it is a safer form of hormone replacement therapy. It's being marketed on TV right now to deal with postmenopausal osteoporosis. Let's see if raloxifene, an estradiol-like molecule, but not quite estradiol, will have beneficial or deleterious effects on inflammation and IMT progression. 142 healthy postmenopausal women, no menses in 5 years. Their FSH was elevated. That's the hormone that the brain makes to say ovaries work harder. That's a sign of ovarian failure or menopause. None are on hormone replacement therapy. No known cardiovascular disease. None with major risk factors, diabetes, hypertension, or smoking. Baseline measurements, you look at the labs, you do the mean IMT of the common carotid, the bifurcation of the internal carotid, randomize them to receive raloxifene, which is Evista, or placebo. Repeat the baseline studies at 1.5 years. Double-blind protocols followed. Neither the researchers nor the subjects knew who was getting the Evista, who was getting the placebo. LDL cholesterol fell with raloxifene, but it rose with placebo. HDL rose 4 points with raloxifene. It fell with placebo. So there was a favorable effect on lipids with Evista therapy. The HOMA index, which is a marker of insulin insensitivity, a pre-diabetic situation which is caused by inflammation, didn't change with placebo therapy, but it fell with raloxifene. So it had an anti-diabetic effect. It improved insulin sensitivity. Soluble vascular adhesive molecule 1 is a marker of endothelial function. Basically, it means the white cells can more easily stick to the intima and form plaque. We would like to see a lower VCAM1. It fell with Evista, not with placebo. Interleukin 6 is a nasty inflammatory marker that gives rise to C-reactive protein. Tumor necrosis alpha is a nasty inflammatory marker that damages the heart cells. It fell with Evista, not with placebo. Adiponectin is a hormone that is released when you are losing body fat. And adiponectin protects against cardiovascular disease. So with the Evista therapy, there was favorable effects on fat metabolism. Adiponectin rose, and that has positive prognostic effects. Mean carotid IMT rose significantly. It rose 86 points over 1.5 years. With placebo therapy, it rose only 11 points with raloxifene. So Bioidentical estradiol therapy is effective, and so is Evista, the selective estrogen receptor modulator agent. To summarize hormonal influences on IMT, hypothyroid status of any degree, frank hypothyroid and even subtle subclinical hypothyroid status increases the rate of IMT progression. This can be rapidly rectified with physiologic thyroid replacement. Statin therapy will have the same effect on the IMT, but leaves you hypothyroid. If it was up to me, if I was hypothyroid, I would want to become euthyroid as opposed to taking a man-made molecule, a statin, although a statin will work. In men, men with low testosterone and or high estradiol, that's associated with an increased risk of IMT progression. No studies are currently available to look at the effect of lowering estradiol or raising testosterone on IMT, but I've got 100 studies showing benefits of testosterone replacement or lowering estradiol to improve symptoms, treadmill time, and outcome in men with cardiovascular disease. One would assume that dealing with testosterone estradiol would also lower the rate of IMT progression, as was shown in women with bioidentical estradiol. In women with premature menopause, we know that estradiol decreases inflammation, IMT progression. I didn't present that study. Women with surgical menopause, but in women with biological age-related menopause, this is a time of vascular inflammation and rapid progression in IMT. This progression is blunted by bioidentical estradiol and or statin therapy, and progression is blunted by raloxifene as well. Next, we're going to move on to a section discussing the link between inflammation and infection and IMT and cardiovascular disease in general. This section looks at the relationship between inflammation and infection and carotid artery intermediate thickness. Let's start with sleep apnea. 52 otherwise healthy American men not on medication, 36 with newly diagnosed sleep apnea. Sleep apnea occurs when you slow down your breathing rate or actually stop breathing. That's called apnea during sleep. 36 men with recently diagnosed sleep apnea, 16 control subjects who were also overweight but did not have sleep apnea. None of the subjects had high blood pressure, diabetes, smoking, or known cardiovascular disease. Overweight men with or without sleep apnea. You're going to evaluate the severity of the sleep apnea. There's a questionnaire one fills out as to how the sleep apnea is interfering with your life. That's the Epworth Sleep Scale. You're going to do a sleep study. The technical name is polysomnography, and you look at the apnea-hypopnea index, events per hour where breathing is abnormal. And if you have 5 to 20 events per hour, that's mild sleep apnea, 21 to 30, that's moderate, above 31, that's severe. You're going to do the carotid ultrasound, get the mean IMT of the common carotid and the bifurcation, and you're going to look for the presence of plaque, which is wall thickening, focal wall thickening above 1.5 millimeters, or calcification. You're going to measure inflammatory markers, interleukin 6, interleukin 18, C-reactive protein, bad guys at 5 in the morning after you've had this night of interrupted sleep, where your oxygen levels are going up and down. Will these periodic reductions in oxygen cause inflammation? Will these periodic reductions in oxygen due to sleep apnea lead to increased IMT? We're going to correlate IMT with inflammatory markers and the severity of sleep apnea. Now, the obese controls, their Epworth Sleep Scale was 8. Those with mild sleep apnea, they were 10. Moderate to severe is 12. These are symptoms related to disturbed sleep. The apnea-hypopnea index, how many times you actually stop breathing, 3 times an hour in the overweight controls. I guess you could say technically they had early sleep apnea, but it wasn't felt to be significant. With mild sleep apnea, it's 11 episodes an hour. With moderate to severe, it's 48 episodes per hour. C-reactive protein, interleukin 6, interleukin 18, bad guys, inflammatory markers were greater in those with mild sleep apnea than in the overweight controls, and were sky high in those with significant sleep apnea. Sleep apnea leads to vascular inflammation, a bad sign. Let's look at carotid mean IMT on the top. The obese controls, their mean IMT is 0.71. Mild sleep apnea is 0.92. Moderate to severe sleep apnea, 1.16. Sleep apnea leads to inflammation, leads to increased IMT. IMT leads to increased plaque, so we aren't surprised to see that the percentage of the subjects with visible plaque rose with increasing degrees of sleep apnea. Here we're going to look at the correlations between increasing IMT and increasing C-reactive protein, interleukin 6 and interleukin 18. The thinking is that the sleep apnea with the periodic reduction in oxygen produces inflammation. The inflammation causes endothelial dysfunction, leading to increased soft plaque deposition, increasing IMT, which predisposes towards plaque formation. I have a lot of trouble convincing patients to undergo sleep studies and to deal with their sleep apnea. But sleep apnea is a key critical driving force behind high blood pressure, atrial fibrillation, and cardiovascular disease. And the predisposition to these diseases associated with sleep apnea is obviously not something we can totally blunt with drug therapy and surgery. So dealing with sleep apnea is very important. What about air quality? 859 individuals living in the Los Angeles area, an area not known for good air quality, they did not have known cardiovascular disease. You're going to look at their mean common carotid IMT, baseline health and socioeconomic data, and you're going to estimate their exposure to PM 2.5 particles. These are particles 2.5 microns in diameter. These are air pollutants small enough that you can inhale them into your bloodstream. And we know that this leads to abnormal physiology, endothelial dysfunction. And you're going to estimate their PM 2.5 exposure by their zip code. Now the group mean PM 2.5 exposure was 20 micrograms per square meter of cubic meter of air. The range was 5 to 27. You're going to stratify them into quartiles of good versus bad air and correlate their mean IMT with their PM 2.5 quartile. And what you find, individuals with the lowest amount of particulate matter in their air, inhalable particulate matter, had the lowest IMTs of 0.708. As air quality deteriorates, the IMT rises. Pretty big difference. They all live in Los Angeles. They're otherwise the same. Those who are living in the more polluted areas of Los Angeles, their IMT is 0.731. Those that are living in an area of better air quality, it's 0.708. In this on the right, we're going to plot change in mean common carotid IMT per 10 microgram per cubic meter increment in the PM 2.5, and individuals, women were affected more than men. Individuals with hyperlipidemia were affected more than individuals without. The air pollutants are oxidizers. So high cholesterol, high LDL is a problem, but it's really a problem when it's oxidized. Smoking cigarettes oxidizes your LDL, thus the synergy between smoking and hyperlipidemia. Same situation between air pollution and hyperlipidemia. The air pollutants are oxidants. They oxidize your LDL, causing heart disease. It's a disturbing fact that the average American loses 2 years of life solely due to the adverse consequences of air pollution. IMT and highway toll collectors. 61 highway toll collectors in Kanash, Turkey. Fairly young, mean age 36. Most of them had smoked. Their mean smoking pack years was 11. None with hypertension, cardiovascular disease, lipids, or diabetes. And the control group were 48 healthy volunteers, a little bit older, but still fairly young. They smoked about the same degree. And again, none had hypertension, cardiovascular disease, lipids, or smokers. Basically the same age, no other risk factors, Same number were smokers, same smoking burden, but some were toll collectors standing on their feet, inhaling automobile exhaust, and others had other jobs. You're going to measure their mean common carotid IMT, correlate the IMT with age, smoking history, and how long they worked or did they work at a highway toll booth. The mean IMT is 0.8 in the toll collectors, 0.6 in the controls. Standing there all day, breathing automobile exhaust is not very good for you. Here we're going to look at the mean common carotid IMT versus years of service in the highway department. Below 10 years, you're 0.7, 10 to 20 years, you're 0.8, above 20, 0.85. So exposure to the automobile exhaust is not a good thing. The longer you're exposed, the greater will be your IMT. Here we're going to correlate the mean IMT with smoking history. In blue are the toll collectors, in red are the controls. Those who were not heavy smokers below 10-pack years, they had thinner IMTs than the heavier smokers, but those who were toll collectors they were 0.7. The minimal smokers who had other jobs were 0.6. 10 to 20-pack years, above 20-pack years, smoking does increase your IMT, but nonetheless it's higher in the highway toll workers. If we look at the mean common carotid IMT versus age and work type, if you're above age 45, you have a greater IMT than if you're younger, below 35. That makes sense. But at all age ranges, the toll collectors had an increased IMT. So age increases your IMT, smoking increases your IMT, but standing there inhaling automobile exhaust all day dramatically increases your IMT. Allergic rhinitis, asthma, and IMT. Here we're going to look at the Army study, atherosclerosis risk factors in male youngster study. 141 18-year-old Austrian men who are registering for the armed service. In Austria, everybody registers for the armed service, undergoes a physical exam. Now, those with overt asthma, a few were excluded. In the 141 subjects without overt asthma, you're going to evaluate for allergic rhinitis. That's chronic runny nose. 24% had allergic rhinitis, which is allergic mediated. 2% had slight asthma along with allergic rhinitis. You're going to measure their IgE levels. That is the allergic gamma globulin. Individuals with an allergic diathesis have high IgE. So look at standard risk factors. You're going to do a mean maximal composite IMT of the common carotid, the bifurcation, the internal carotid, and the superficial femoral artery in the groin. You're going to define high IMT as the 90th percentile, above 0.8. And you're going to correlate IMT with parameters of allergy. Now, why should allergy be associated with cardiovascular disease? Well, chronic allergy is chronic inflammation. Many of the mediators of the allergic response, these inflammatory factors, are also mediators of atherosclerosis. So it's not unreasonable to hypothesize that chronic allergy, such as allergic rhinitis, could cause cardiovascular disease, could increase your IMT because it's associated with chronic inflammation. Now, overall, 24% of these Austrian 18-year-olds had some sort of allergy or asthma. But those with higher IMTs, the top 10%, 37% of them had more allergy and asthma. The mean IgE level, the immune mediator of asthma, was much greater in those with high IMT. So in these 18-year-olds who are otherwise in great health, those with chronic allergic phenomenon and allergic inflammation at just age 18 had higher IMTs than their non-allergic colleagues. Another study, the Bruneck study, in an older patient population, 826 40 to 70-year-old men and women residing in Bruneck, Italy. You're going to evaluate for allergic disorders 4%, allergic rhinitis in 0.5%, asthma 1.3%, both in 1.1%. Standard risk factors. You're going to do a carotid ultrasound, and again at 5 years, looking for new plaque or progression of pre-existing plaque. and roughly half of the subjects showed some plaque progression. Let's correlate allergy status with the presence or absence of plaque progression. Now, overall, 4% had an allergic disorder, but those who had plaque progression is 6.5% versus 1.5% those who did not progress. Those who progressed had higher IgE levels than those who did not progress. So in 18-year-old kids to middle-aged to senior adults, individuals with chronic allergic inflammation, allergic rhinitis, asthma, high IgE, that chronic inflammation is associated with increased IMT, or in this study, an increased rate of plaque progression. Endotoxin load. Endotoxin is bacterial lipopolysaccharide. It is a component of the outer cell wall of bacteria that causes inflammation. If you have an infection and sepsis, you feel sick, you're febrile, you're sweating, that is the immune system's response to bacterial endotoxin. So bacterial endotoxin triggers inflammation. Let's look at endotoxin load and plaque progression. 516 subjects, 86 men and 86 women in their 6th, 7th, and 8th decades residing in Bolzano province, Italy. Record at baseline the presence or absence of chronic infections, chronic GI, urinary, or a respiratory infection, their endotoxin levels, which you can measure in the blood, smoking status, carotid ultrasound for plaque or wall irregularity. You're going to repeat the ultrasound in 5 years looking for new or incident atherosclerosis, plaque where there wasn't plaque before. We're going to correlate endotoxin level, smoking, and infection with new plaque status. Now, unfortunately, we're all chronically infected. We all harbor bugs. We may not be overly sick, but we are all home to all kinds of different bacteria and viruses and unfortunately parasites. So nearly all blood specimens contained endotoxin. The median value was 14 with a range of 6 to 209. The levels were higher in women, probably because women are more likely to harbor chronic urinary tract infections, and in smokers because smokers have more infections than non-smokers. Now, here we have individuals who did develop new plaque on the right, on the left those who did not. And they differed within a number of risk factors you'd expect, but the endotoxin load was 50% greater in those who developed plaque, and the C-reactive protein was 4.5 in those who developed plaque versus 2.4 in those who did not. So endotoxin load reflecting infection, C-reactive protein in reflecting inflammation, which is likely due in part to infection, is associated with an increased rate of new plaque formation. Here we're going to stratify the subjects into 10% brackets or deciles of endotoxin. Those in the upper 10%, their risk for developing plaque was much greater than those in the lower 90% in all comers. But those who are current and ex-smokers, those in the upper decile, there was a dramatic relative increase of plaque formation. So there was a synergy between chronic infection and smoking. If we define, high endotoxin load, the top 10% is an endotoxin burden above 50 units, your relative risk for developing new plaque rose 70% in non-smokers. In ex-smokers, it was 9.5-fold increase, and in current smokers, it was 15-fold increase. So the endotoxin load is associated with plaque progression, but particularly in smokers. Here we're going to look at endotoxin loads above 50 in the top 10% with the hatched bars, and the clear bars were those with lower levels. The relative risk of a high endotoxin burden you can see is much greater in smokers and ex-smokers than in non-smokers. We can also look at the relationship between no infection and infection in the graph on the right. Individuals who did not have an infection, who did not have smokers, were at low risk. Individuals who were current or ex-smokers without infection had increased risk. Individuals with chronic infection who were non-smokers had an increased risk, but individuals who were smokers with infection had the greatest risk. So there's a synergy between infection, smoking, and endotoxin load in predicting risk increase. So circulating bacterial endotoxin is a bad actor. It provokes endothelial dysfunction, abnormal physiology, circulatory inflammation, promotes abnormal clotting and plaque deposition. We know that some actually cause the heart cells to commit suicide, called apoptosis. Where do we get these chronic infections that put bacterial endotoxin in our blood? Chronic and recurrent bacterial infections in the gut. Individuals with congestive heart failure, their bowel walls edematous, and bacterial products leak into the blood. That's why heart failure is associated with inflammation. But endotoxin chronic infection is associated with inflammation, increased rate of IMT and plaque progression, which is amplified by chronic infection and in smoking. Let's look at infection, inflammation, and IMT. 502 Europeans presenting with known or suspected coronary disease. Look at standard risk factors. You're going to measure their serum IgG and IgA antibodies against a number of bugs. Now, IgA rises with an infection over a mucosal surface, the GI tract, the upper respiratory tract. IgG rises in response to a deeper infection. But if you had an IgA or IgG antibody against the common bugs, this was recorded. H. pylori causes peptic ulcer disease. Chlamydia pneumoniae and Mycoplasma pneumoniae cause infection. Cytomegalovirus, Epstein-Barr virus, herpes simplex 1 and 2 are common chronic viral invaders. So you look at your immune, your infectious history, your burden of past infections. And you're going to look at the common carotid artery mean IMT. You're going to repeat the IMT at 2.5 years and stratify the subjects by degree of progression. Those in the first quartile didn't change or they regressed. Those in the second quartile progressed up to 40 points a year. Those in the third quartile progressed from 40 to 100 points a year. Those that progressed above 100 points or 0.1 millimeters, they were considered fourth quartile progressors. Now, you can look at a number of different risk factors in the progressors versus the non-progressors, and yes, the progressors were more likely to be hypertensive and to be smokers. But if you looked at the percentage of the subjects that had abnormal antibodies to all these bugs, there was a relationship, particularly with Chlamydia pneumoniae, which is the most common cause of upper respiratory infection in adults. So those that had evidence of infection with Chlamydia pneumoniae were more likely to show plaque progression. But it's not just one bug. Different groups have tried to say it's Chlamydia pneumoniae, it's Nanobacterium sanguineum, it's H. pylori. My bug is the one causing cardiovascular disease. But those studies have not been successful. It's actually our infectious burden. Weak immunity leading to chronic infection, the more bugs you're infected with at various times in your life or concurrently, leads to inflammation that causes the disease. Here we're going to look at the baseline IMT on the left in the upper slide. 0 to 3 past infections, your IMT is 0.7. 4 to 5 infections, it's 0.72. 6 to 8 infections, it's 0.78. If you look at the final IMT later on, the more infections you have, the greater is your absolute IMT, and the change in IMT, millimeters per year, disease progression, it's 30 points with 0 to 3 infections, 40 points with 4 to 5, it's 70 points per year, 6 to 8. So prior and concurrent infection, your total global infectious history is associated with chronic inflammation and more rapid progression of the IMT. Your relative risk for being a progressor, progressing at 100 points, rises dramatically with the more infections that you've been exposed to. 50% of those that had 6 to 8 antibodies progressed versus 20% of those with 0 to 3 antibodies, reflecting 3 different prior infections. Now, infections and long-term outcome. Just over 1,000 consecutive patients undergoing diagnostic angiography that had at least a 30% narrowing. So it didn't have to be severe plaque, but some plaque, and the absence of malignancy or febrile illness that might confuse the interaction between infectious history and disease progression. You're going to measure the serum antibodies IgG and IgA against the common bugs, look at standard risk factors, follow up over 3 years, 78 cardiovascular deaths, 22 non-cardiovascular deaths, 61 non-fatal heart attacks. Let's correlate outcome, not IMT progression, but outcome. But of course, IMT progression and outcome do appear to be tightly correlated. We're going to look at the correlation between infectious burden, outcome, and traditional risk factors. 3-year mortality was 4% in those with a low infectious burden, 7% of those with an intermediate infectious burden, 13% in those who had had a number of infections in the past. If we look at seropositivity, that is IgG or IgA antibodies, to bacterial infections or to viral infections, event-free survival falls with the greater your infectious burdens. If you look at bacteria and viruses together, the fewer bugs you have, the more likely you are to survive. The more bugs you've been exposed to, the more likely you are to die over the relatively short-term course of the study. One of the most common chronic infections is periodontal disease. In this study, you're going to carry out a periodontal evaluation in just under 700 adults in Stockholm in 1985, and you're going to have some definitions as to what is periodontal disease. Here they looked at tooth pocket depth above 5 millimeters. The rest were free of periodontal disease. 16 years later, you call them all back for a reevaluation. You get 82 with periodontal disease in 1985 to come in, 31 without disease. You repeat the dental evaluation, look at the mean common carotid IMT, correlate long-term periodontal health with the IMT status, and the individuals with periodontal disease in general did not enjoy the same quality of health as those who had a healthy periodontal health. If we look at the mean common carotid IMT, those with periodontal disease, it's 0.68. Those without periodontal disease, it's 0.58. That's a pretty big difference for a chronic infection of the mouth. If we looked at odds ratios for having a high IMT, periodontal disease was much more powerful a predictor of a high IMT than even was age. So chronic infection is a problem. The most common chronic infection we have is gingivitis and periodontitis. So I want you to work with your dentist to clean up your mouth. What is the link between periodontal disease and heart health? If you're particularly interested in this, I gave a 1-hour talk to a dental group a few years ago. We have that on DVD. But inflammation of the mouth becomes inflammation in the circulation. If you have inflammation in the mouth, you're circulating inflammatory markers, CRP, tumor necrosis factor, interleukin 6, matrix metalloproteinases, all bad guys are elevated. This causes oxidative stress, and it makes your cholesterol go up. Your cholesterol will rise in response to infection, including periodontal infection. So you got a high cholesterol oxidative stress, you're going to oxidize that LDL, you're going to aggregate it, and it's more likely to layer out in your arteries as plaque. If you have periodontal disease, that inflammation leads to hypercoagulability and increased tendency to clot. The bugs in your mouth will invade your arteries. A study was done where they took plaque samples from carotid arteries and coronary arteries and cultured bugs. 2/3 of the plaque samples had live bugs. We have live bugs living in our plaque, and 1/3 of them had periodontal bugs that had left the mouth and gone into the plaque. We also can have an autoimmune attack, which I'm going to explain in just a minute, due to periodontal disease. Anyways, periodontal disease leads to increased risk of cardiovascular disease and increased overall mortality. I want to talk a little bit about a concept of autoimmunity and heat shock proteins. Why do we have more heart attacks in the winter than in the summer. Why do smokers particularly have more heart attacks in the winter than in the summer? What is the interaction here with infection? If we are exposed to a bacteria, say Chlamydia pneumoniae, our immune system recognizes that this bug is a bad guy, and it'll make antibodies designed to bind to the immune signals, the antigens on the Chlamydia pneumoniae, and then we're going to kill them. So we make these antibodies designed to specifically kill Chlamydia pneumoniae. So the bug knows it's under attack. It knows it's going to die. As a defense mechanism, the bug will elaborate into its cell membrane proteins called heat shock proteins. And these will stabilize the cell membrane of the bacteria. You can think of the bacteria as circling their wagons to make them resistant to the human immune system attack. So what we humans will do, well, we're going to make antibodies against the C. pneumoniae heat shock proteins, and we're really going to kill it. Now, this heat shock protein is a really effective protein. It helps protect bacteria from all sorts of attack. And it works so well that Mother Nature has conserved it. The amino acid sequence of the heat shock protein of a bacteria is 98% identical to that of a human. We haven't changed a whole lot. We're only 2% different from a bacteria. The heat shock protein that we make is very similar to the heat shock protein that the bugs make. Now, if I'm a healthy guy and my cells are functioning well, they're not under any stress, they're not making heat shock proteins, and I got a bug, I'm going to make antibodies to the bug's antigens and the bug's heat shock proteins, and I'm going to kill it and I'm going to be fine. But let's say I'm not healthy. Let's say I'm metal overloaded, or I'm diabetic, or I'm a smoker. Those noxious influences will damage or stress the endothelial cells within the intima of my arteries. And because of that stress, those cells are worried about survival. They will make heat shock proteins. And the heat shock proteins elaborated by our stressed arterial cells look an awful lot like the heat shock proteins on the bugs. And the more infections you've got, the more anti-heat shock protein antibodies are floating around in your blood. So when your own cells demonstrate a heat shock protein because you're a smoker, your own immune effector cells will attack your arteries, and cause inflammation and cardiovascular disease. So non-smokers get a bug in the winter, they kill it. Smokers get a bug in the winter, the immune system, in the process of killing the bug, may kill you. That is one of the interactions between smoking and other causes of inflammation and bacterial infection. Okay, so infection's a problem. It causes inflammation, hypercoagulability, hyperlipidemia, autoimmune attack against the arteries. What are we going to do about it? What if we kill these bugs with antibiotics? Will that be helpful? Will that blunt the adverse effect of infection on progression of IMT? Here we're going to look at 272 patients who had an ischemic stroke. They didn't bleed into their brains, they had a reduction in blood flow, and they've healed up completely. At the time of the stroke, you're going to look at their common carotid artery mean IMT, and you're going to measure IgG and IgA antibodies against C. pneumoniae. And if it was above 1 to 64 for the IgG or 1 to 116 for the IgA, that was considered positive. You're not going to do anything. You're going to repeat the IMT 3 years later and correlate the degree of IMT progression with their immunoglobulin status to C. pneumoniae 3 years earlier at the time of the stroke. Then you're going to randomize these subjects, now 3 years out from the stroke, to a 30-day course of roxithromycin, which is kind of like a Z-Pak, Zithrobax, only over a longer period of time, or placebo. And then you're going to repeat the IMT 2 years later to see if the 4 weeks of antibiotics had an effect. Now, let's look at the C. pneumoniae status at the time of the stroke. 46% were positive IgG or IgA, 42% IgG, 41% IgA. So a little bit less than half had evidence of a pneumoniae infection at some point. Now let's look at the yearly progression of the IMT between the time of the stroke and the follow-up IMT 3 years later. Those who were negative for pneumoniae progressed 70 points per year. That's pretty rapid progression, but again, these were older, sicker people. Those positive for pneumoniae progressed almost twice as rapidly, 120 points a year. So prior or current infection with pneumoniae is associated with more rapid disease progression of the IMT, similar to the other studies done in Europe. Now, you've got these people 3 years out from their stroke, and you're going to treat them for 3 weeks with an antibiotic, and then you're going to repeat the IMT 2 years later. Will 30 days of antibiotics have an effect on IMT progression over 2 years? Those who were negative for chlamydia, who did not have a chronic infection, at baseline they're progressing at 70 points a year. Those on antibiotic therapy progressed over the next 2 years at 60 points. Those that had placebo, 70 points, there was no change. So giving an antibiotic to someone who doesn't have an infection doesn't do anything. Those that had the infection, and presumably the bug is still alive, but it's an intracellular bug, it's hiding, it's very stealthy, but it's causing inflammation. They had been progressing at 120 points per year. Those given placebo continue to progress rapidly, 110 points per year. Those that had a month of antibiotic therapy, disease progression was blunted. It was down to 70 points per year. So 30 days of antibiotics to people with a chronic infection with a bug susceptible to the antibiotic will slow down the rate of disease progression. Of the chlamydia pneumoniae positive patients, those on antibiotic therapy, only 34% progressed rapidly, greater than 100 points a year, but 77% of those on placebo did. So this is one study showing that a short course of antibiotics has a benefit on the rate of IMT progression. This study did not show a benefit on survival. Those that were positive for pneumoniae were more likely to have an adverse event. Antibiotic therapy did not lower that risk. However, had the study involved a longer course of antibiotics or different types of antibiotics, or if I was doing it, nutritionals to improve the endogenous immune system response, I think we would see an improvement in outcome. And my approach, of course, is to take proactive steps to decrease your risk of infection. Antioxidant vitamins, essential fatty acids. There are a number of supplements that non-specifically improve immune system function. I don't want you to get chronic infections. I don't want to get you to get to this point where you've had a stroke and we're going to give you antibiotics. I want my patient to have a healthy immune system so they can resist infection, because I know that chronic infection, or the more infections you've been exposed to, is going to increase the rate at which your IMT progresses, and that'll be associated with an increased risk of disease progression and future events. There's a genomic interaction here. Let's look at the interaction between genomics, acquired inflammation, and IMT. Our genetics will determine how we respond to infection, how much inflammation we mount. 810 individuals residing in Bolzano province, Italy, in their 5th to 8th decades, look at standard risk factors, and you're going to look at some genetic variants with respect to inflammation. If they had a genetic variant associated with increased levels of interleukin 6, that's the bad guy that causes C-reactive protein. So they were genetically predisposed to exuberant inflammation. You'll look at the percentage that have chronic infection, 32%, and you're going to look at their mean maximal common carotid IMT, which was 0.93. You're going to correlate genomic tendency to inflammation with acquired inflammatory status from infection and IMT and look for an interaction. Now, 73% of the subjects did not have any of the genomic variants. 24% had one, and 3% had 2 or 3. And the mean maximal IMT was greater in those with the pro-inflammatory genomic variants. So if you enter this world with a genetic tendency to overdo it with inflammation, that's associated with increased soft plaque deposition, because inflammation, either acquired from infection or intrinsic to you on the basis of genetics, is associated with an increased rate of soft plaque formation. Here we're going to look at the mean maximal common carotid IMT. Blue are non-smokers, red are current or ex-smokers. And as we move to the right, these individuals have a greater genetic burden of inflammation. You can see in the non-smokers in blue, the genetic predisposition was not that important. In the smokers, they had greater IMTs than the non-smokers, but the synergy between the risk of smoking and the genetic predisposition was enhanced. So if you don't have a lot of reasons to be inflamed, the genetics doesn't bother you as much. But if you got a lot of reasons to be inflamed, such as smoking, and we know smokers get more infections, the genetics becomes more of an issue. I don't want anyone to smoke, but if you've got a genetic predisposition to inflammation, smoking is particularly malignant for you. Here, we're going to look in blue are people without chronic infection. In red are people with chronic infection. The same situation as in smoking. Chronic infection is more of a problem if you're genetically predisposed to infection. We don't want anyone to have a chronic infection. We don't want anyone to be a smoker. But if you're genetically susceptible, it's more of an issue. The same thing in the bottom slide with diabetes or obesity. Diabetes and obesity is inflammatory. The relative increase in IMT of being diabetic is far more of an issue if you're genetically predisposed to inflammation. So it's acquired inflammation from obesity, overweight, infection, smoking, interacting with your own innate tendency to overdo it with inflammation on a genetic basis that determines how much soft plaque will be deposited. If we look on the bottom slide at increasing degree of pro-inflammatory genetic variants and increasing causes of inflammation such as infection, smoking, diabetes, we can see a clear interaction. There's a synergy between genetic and acquired causes of inflammation. And you may find this droll and boring, and you may want to go on to the next DVD which talks about the fun stuff. But to me as a clinician, I find this interaction between genetics and environment and lifestyle totally fascinating in explaining disease in my patients. We're getting more and more involved in genetic testing, and I'm seeing how certain patterns of risk factors are more or less of a problem in individuals as a function of their genetic makeup. So to summarize the section on inflammation and infection in IMT, inflammation from any source, it doesn't matter where it comes from, inflammation's a bad actor. It increases IMT. Sleep apnea, environmental such as automobile exhaust, allergic disease, infection, acute and chronic. We focused on periodontal disease, but the same principles apply to any chronic infection. There's a genetic predisposition to inflammation that interacts with all other acquired causes of inflammation. Powerful interactions between genetics, smoking, and infection. There's some role for antibiotic therapy. I think there's a stronger role for general immune system support and supplementation. So we've been talking about the physics with which we acquire the ultrasound, the IMT measurement. We've talked about normal and abnormal values. We've talked about the correlation between increasing IMT and increasing cardiovascular disease burden throughout the body. And we've talked about the use of the IMT to predict your risk of an adverse event. We talked about hormonal influences on IMT, and we concluded the first part of our presentation with a discussion of inflammation and infection in IMT. On the second disc, we'll talk about the interaction, the relation between endothelial function and IMT, then all the other causes of IMT that you'll find surprising and interesting. And then we'll talk about how are we going to stabilize or reverse the IMT, first pharmacologic approaches, then nutritional approaches. Then I'm going to summarize and propose to you an integrative approach to stabilizing or regressing your IMT. We appreciate your attention. Thank you.